2024, Dr. Pratima Radhakrishnan Madam. And I extend a very warm welcome to all of you and would like to start the program. Jagruti, please. Please unmute yourself, Jagruti.
Okay, there was a lot of disturbance. Good evening, everyone. Heartfelt welcome. And without wasting time, we will start. So our guest of honor is Dr. Rajendra Pardesi, sir. Sir, welcome. Okay, so he is our past president AMOGS, and ma'am, should I go through this? Madam,
Yes,
sir is there? Yeah. So he has presented 27 papers, presented in national conferences up till now, 6 times best paper awardee in FOXY, AICOG conferences, faculty in COG 2011, and 13 Bangkok, faculty at FIGO 2006, Kuala Lumpur, Malaysia, and FIGO FIGO 2012. Sorry, chairpersons of Food and Drug Committee FOXY awarded Dr. Hansotia Best Committee Award FOXY, VP FOXY 2019-20, and VP AMOX 2020. And obviously our past president AMOX 2022-24. We welcome you, sir. Thank you, ma'am. I think guest of... Hello?
The sir has to unmute him. Sir, Pardesi, sir.
Sir?
Good afternoon,
sir, can
everybody.
Yeah.
Hello.
Nice to see you.
Am I audible?
Yes, sir.
Yes, sir.
Hello.
Yes, sir, you're audible.
Sir, you're audible.
Good afternoon, everybody. Respected chief guest and our ever active smiling president of AMOG, Dr. Kiran Kurtakoti, sir, and guest of honor, Dr. Chamila, Dr. Ame Purandare, sir, and our AMOG chairperson, Dr. Rashmika, Dr. Sujit Kondkar, Dr. Pura Loda. First, I wish to congratulate conveners, Dr. Rashmika, Dr. Jagruti, Dr. Jaya Tolaskar, Dr. Sujit Kondkar, for organizing this AMOG's Yuva webinar. And listening to Dr. Pooja Loda and Dr. Pratima Radhakrishnan, I think this will be an academic feast on fetal medicine. I wish to listen Dr. Subodhi Rizvi also. I wish every success to this webinar on fetal medicine topics. They are very important in our day-to-day practice. I wish every success to Dr. Rashmika for her future endeavor in FOXY. In this forthcoming as chairperson of Practical Obstetric Committee, I wish every success to Dr. Sujit Kondkar also for future endeavor in FOXY as chairperson of Imaging Science Committee. Wishing every success to the webinar. Thank you so much for inviting me. Thank you.
We are truly blessed, sir. तुमचा नेहमीच आशीर्वाद आमच्या सोबत असतो. I would like to introduce our next guest of honor, Bhavna. So with great honor, I would like to introduce Dr. Chamila ma'am, a lady who needs no introduction. She is Vice President elect FOXY 24. She is Director at Aditi Hospital, Trichy. She is past chairperson of the CRC Committee FOXY, ICOG Governing Council member 21-23. She is National Coordinator for UNICEF FOXY PCM Medha, WHO CRO MDSR India member. She is past secretary of the Trichy OBGYN Society, past president Menstrual Hygiene Management Consortium.
Thank you.
And we are eager to listen to you, ma'am.
Thank you, Jaya. Thank you so much. It's an honor to be in a program of AMOGS where Dr. Kiran is the chief guest. Dr. Pardesi sir is the guest of honor, as well as Dr. Amaya Purandare. All very well known to most of us in South. Pardesi sir is well known and is a mentor to many of us throughout India, and he has guided so many of us. And Amaya is always a friend. And when you think of Amaya, it's always clarity that comes into the mind, like how clear he is in his thoughts. And even his ragging, he was quite clear. Uh, so it's a wonderful program which has been convened by Reshmi. And Reshmi is a very, very sweet person and has always been a good academician also. And that's a very rare combination of sweetness with academics, which doesn't happen so often. And honored to be in a program where Dr. Jakruti, Dr. Jaya, and Dr. Sujita are convening. And as Sir said, we are all with most of you because we know you for a long time and we've seen the work which you're doing, and that will be always a stepping stone for you in your future. And it's an honor to be in a program where Dr. Usha and Dr. Revati Sadasivam from E Road have joined, great friends of us. And the speakers, Dr. Pooja, Dr. Subhoyi, and Dr. Pratima, all great speakers on fetal medicine. And chairpersons, Dr. James, Dr. Sujamal, Dr. Nagaratna, and Dr. Sumaya. Yeah, it's an honor to be invited for this program, and I would like to wish both Reshmi and Sujit all the best for their endeavors, as Pardeshi sir said. And a great going Reshmi as always, coordinating so well and always keeping in touch at the right moment. Thank you so much.
Thank you so much, respected Shamila Madam, for all the kind words of appreciation. Thank you very much. We are very grateful and very humble. I would like to introduce our next guest of honor, Dr. Ameya Purandaresan, and actually he needs no introduction. He is the Vice President of AMOX and is also a consultant OBGYN at Purandare Hospital and KJ Somaya Medical College. He is a consulting OBGYN at Sir H.N. Reliance Hospital, Bhatia, Messina, and Mumbai Police Hospitals. He has been Joint Secretary of FOXI 2019 and Chairperson of Food and Drugs Committee in FOXI in 2015 to 17, with many awards, accolades, and research paper publications to his credit. We would like to extend a very heartfelt welcome to Dr. Ameya sir. Ameya sir, as we all know, has reached to many many hospitals through his immense work in Manyata, which is a project for mothers, and directly he has helped in quality improvement and building very confident teams in the private sector of hospitals. We welcome you, sir, and we would like to hear from you.
Thank you, Rashmi, for those kind words. First of all, like to express my sincere regards to Pardeshi sir, immediate past president of AMOX, Dr. Kiran Kurtakoti, present president of AMOX, Dr. Charmila, vice president of FOXI, Dr. Rashmi, doing excellent work as high-risk pregnancy committee chair of AMOX, Dr. Sujit Konkar, also doing excellent work as imaging science committee chairperson. The coordinators for today, Dr. Murki, Dr. Pore, also the invited speakers. I think we all know that our focus remains on maternal health, but I think the key component of any pregnancy is the outcome. And the outcome depends on not just the healthy mother, but equally important is the healthy baby. Because if it is a healthy baby, it is going to ensure that it is going to be a healthy family and a healthy nation. And therefore, I think the equal, or if not more importance, should be given to fetal medicine in the evaluation of every pregnancy. Keeping this in mind, I congratulate all the conveners for today for bringing about such a good program where we have got eminent and sought-after speakers like Dr. Pooja Loda, Dr. Pratima Ramkrishnan, and Dr. Subodhi Rizvi, all talking on very important topics. And with the vast experience and their depth and knowledge in these subjects, I think it is going to benefit certainly all the attending delegates, because Rashmi and Sujit have definitely chosen very practical and pertinent topics. Last but not the least, I take this opportunity to personally wish best of luck to to Rashmi and to Sujit for their upcoming endeavors and desires in Foxy. I am sure with the hard work that both of you have shown in AMOX and with your spirit of inclusiveness, it will definitely help you in achieving whatever you desire to do. I think that you are assets to AMOX and you will definitely be assets to Foxy one day. Thank you once again and congratulations and wishing you all the best, not just for this webinar, but in your journey in AMOX and Foxy. Thank you.
Thank you.
Thank you very much, sir. Thank you for all the kind words. Thank you so much. I would like to take permission from our guest of honor and proceed towards our scientific session. I would like to ask Sujit sir to kindly proceed for scientific session.
Yeah. Welcome to the first session of this webinar. So I'm very much delighted to welcome and introduce chairpersons for first session. So I welcome and invite Dr. S. Usha ma'am. She is Senior Fetal Medicine Specialist and Consultant in High-Risk Obstetrics. She has more than 30 years experience in Lotus Multi-Speciality Hospital. She has been a past president of Erode Obstetrics and Gynecological Society. She is member of ISOG and Foxy. She has been faculty in various national fetal medicine, obstetric gynecology conferences and workshops. She has been conducting regular training programs for ultrasound and colposcopy. And very important and notable thing is that she is a Rotarian volunteer in performing high-risk gynec surgeries in Nigeria every year. Our next chairperson is Dr. Revati Sadasivan. She is MD Gold Medalist, DNB, MRCOG, Masters in Reproductive Medicine. She is fertility consultant in Erode Maruti Medical Center and Hospitals. She is accredited colposcopist and she has received Young Achiever Award 2016 issued by Lieutenant Governor of Puducherry, Dr. Kiran Bedi. Welcome, Dr. Revati. Now I request Dr. Usha ma'am to introduce our first speaker today, Dr. Pooja.
Thank you, Dr. Rashmi, for having me here. So the first speaker of the day is Dr. Pooja Lata. She is FMF fellow from Fetal Medicine Foundation of UK, and she is presently director of Kangaroo Cradle, a fetal medicine center. She is also attached to Ruby Hall Clinic and Bharati Vidyapith Medical College as a consultant, as well as a trainer and thesis guide. And she has received many awards, to name a few. Indian Medical
Yeah, thank you so
Young
much
Directors
for
Award,
the very
etc.,
kind
etc.
introduction. If I may start, we can keep this time for discussion, if the
Dr. Pooja.
chairpersons don't mind.
Sure.
So thank you so much for the kind introduction. If I could share my screen, please. So, respected President EMOGS, Dr. Kurtakoti sir, respected Pardesi sir, immediate past president, respected Dr. Ameya sir, and the chief guest of honor, and Dr. Rashmi, Dr. Jagruti, Dr. Sujit, Dr. Jaya, thank you very much for a very warm invitation to this webinar. It is my proud privilege to be here today, and I hope I live up to your expectations. All the best, Dr. Rashmi, Madam, and Dr. Sujit, for your future endeavors. On that note, I start with a topic that many of us may feel really bugged about because it keeps confusing us, but the fact remains that it keeps coming back to us. So there is no other way but to really have clarity about it. And today I am going to talk about some very practical case-based scenarios rather than anything theory. And it will only be on double marker. The ultrasound part will be covered by the speakers later. So today I will be covering the clinical aspects of screening versus diagnostic testing, how to interpret and counsel a normal double marker report, and what to do about an abnormal double marker report, and we will touch upon NIPS in the end. This may sound really basic, but when things go wrong and when we go back and see where the things went wrong, it's usually the basics. So let's have all this really clear before we build up upon more complicated things there. Now, this is the whole window of opportunity at 12 weeks. This is the Oscar concept where it is a one-stop clinic for assessment of risk where we don't just do the NT scan, but it's the right time to do an accurate dating. If there is a discrepancy of more than 1 week between the LMP and the CRL, rather than dating the pregnancy at 6 weeks when we can't see the crown and rump clearly, the ISWA guidelines and most guidelines have ascertained that the redating of pregnancy has to be done on the NT scan between 10 to 14 weeks. But then rather than calling her at 10 weeks only to date the pregnancy, it's a practical option to any which way we are going to see her at 12 weeks for an NT scan, so we could date her that time. Now, the main purpose why this whole 12-week scan was started in 1990 by Professor Kipros was actually to look at the nuchal translucency, and so on and so forth. We've slowly added on more things to this 12-week window. Basis of chorionicity, we can do uterine artery PI, pulsatility index, combine it with the PAP-A and so on and so forth, predicting preeclampsia, fetal growth restriction, and we can also predict preterm birth. So this is really an opportunity for fetal triage. I haven't seen this word anywhere, but I like to use it here because we used to have a triage in the casualty where we would decide इस patient को घर भेजना है, इसको ICU भेजना है, इसको ward में भेजना है. So this is the fetal triage module where we are going to decide whether the baby is going to need multiple monitorings or it's going to come back to us only at 20 weeks and so on and so forth. So starting with the screening for Down syndrome. Now, why is universal screening done for Down syndrome? Why don't we choose that somebody who's elder, probably only somebody who's more than 35 should have a Down syndrome screening? Well, that's not going to work because as you can see here, although the risk of Down syndrome does increase with increasing maternal age, but the maximum number of Down syndrome babies are actually born to young mothers, to mothers who are less than 35 years of age. And this is because the overall number of women delivering in that age criteria is way more. So just logically speaking, if you have like 1 lakh women who are delivering at a younger age group, you will have only probably 100 delivering in more than 35 years. And therefore, you'll have more number of Down syndrome babies being born to young mothers. So we cannot choose who's high risk and low risk. As in obstetrics, any low risk can become high risk, and we all know, a lot of us here are fetal medicine people, and we know that even 19 and 18-year-old women can have babies with Down syndrome. Now, coming to the whole concept of screening. Screening is something you apply to everyone. So we've just said that we are going to do a Down syndrome screening for the whole population, not deciding which is low risk and which is high risk. And once you screen the whole population, you find some women or fetuses who are high risk and a few who are low risk. You're going to leave aside the low risk and call them for routine further management. But for the high risk ones, are you going to go and terminate the pregnancy? No. These are only high risk. They are not affected. We have not yet confirmed that these babies have a problem. They have only come as a higher suspicion for the problem. And what are we going to do? Yes, so double marker, when the report comes as high risk, we all have to be really cool in front of the patients. And we all know there's a headache going on in the mind because these numbers are so boggling as to what is happening inside. So once she is high risk, the definite thing you need to do is an invasive test or a diagnostic test to make sure whether the baby is really normal and whether by mistake she was into that group of high risk, which we call as false positive. So she was amongst the high risk, but actually the baby is normal. And how did we ascertain that? Because we subjected this high risk group to a further diagnostic test. So we saw that screening for all, high risk and low risk, you subject the high risk to a better test and then you confirm if the baby is normal, and that's how you go ahead. So this is the whole process of screening. Now, why all the fuss only about Down syndrome and no other syndromes? There are various reasons why Down syndrome has all the hue and cry. And that is because, number one, it is the commonest chromosomal abnormality. Number two, it's one of those chromosomal abnormalities which is very subtle sometimes on ultrasound. So trisomy 13, 18, etc. will hit you in the eye. You cannot miss them on ultrasound. Where they will have an NT of 8, 9, cystic hygroma, cardiac defects. They may have a proboscis. They may have holoprosencephaly. So these are gross defects in trisomy 13 and 18, which are not going to be difficult to pick up. Whereas Down syndrome babies may have a very subtly high NT, like probably 3.1, 3.5. And therefore, because of this overlap of appearance of these babies with the normal babies, it is difficult to pick them up and they could be missed. So this is the first reason why we are really concentrating on Down syndrome screening here. The second reason is Down syndrome babies could live as much as you and me do. Whereas trisomy 13, 18 are lethal. Most of them are not even going to make it till term. And if they do, they are going to die soon after, most probably. Whereas the Downs one are going to live a morbid life, but they will live 40, 50, 60 years, especially if there are no associated cardiac defects. And therefore, we choose Down syndrome to decide all these tests. Now, what are the screening tests? What we do for everyone? The ideal way to screen in the Indian scenario, even today, despite NIPS coming in and amniocentesis becoming very safe, continues to be a thorough NT scan combined with a double marker. For all practical purposes, this is the combined screening to be offered to all women, and it is very much doable even in tier 2, tier 3 places. Where even AMOX can reach, and we have already done and we are planning for more such educational programs where everybody becomes aware of this right of the mother. Now, some people would argue that probably we are more worried about preeclampsia, fetal growth restriction. Ye Downs kya hai? Ye to 1 in 800 risk hai iska. We are not really worried about that in a village. We are more worried about more important things like PIH and IUGR. So let's come to how a double marker may even help in that. So probably at the end of today's lecture, you would be convinced that this is supposed to be not just for the privileged few or the high risk, but for everyone across ages and the country. So what is a double marker? It is a blood test. It's called a double marker because it consists of 2 hormones secreted by the placenta. When can it be done? For all practical purposes, it can be done exactly when the NT scan can be done. So between 11 and 13 weeks, 6 days, you can do a double marker. Although technically you are allowed to give bloods for double marker after 10 weeks, but we will leave that beyond the scope of talk today. What are we testing for? Beta HCG and PAPA. So these are the 2 hormones that double marker is testing for. And what aneuploidies does it test for? Trisomy 21 Downs, Edwards and Patau. So these are the commonest ones, and the double marker helps us in predicting risks for these aneuploidies. Now, if you combine the maternal age with double marker, so you don't do an NT scan, you don't do anything, but because we are hearing a fantastic lecture today on double marker from tomorrow, everybody is going to have a double marker. You combine it with age, you will only pick up 65% of Downs. Okay, so although I am giving this lecture, I would tell you, you would rather do a thorough NT scan rather than running after a double marker. So the priority still remains an NT scan. Adding on double marker will increase the detection rate and reduce the false positive rate. So everything being done together is going to be helpful. But if you ask me which is that one marker, the strongest aneuploidy marker, it is nuchal translucency, done by an accredited scanner in an accredited way and reported in the correct manner. So improvise your skills of doing NT or get it done from a perfect person, because NT alone has an odds ratio of 11. So an abnormal NT, an NT more than 99 centile for a fetus, is 11 times more likely to have a problem than a baby with normal NT. That's how strong that NT is. It is more strong than double marker, than nasal bone, than ductus, than quadruple marker, than triple marker, than everything. Okay. So where you can't afford a double marker, please make sure that a thorough NT scan is done. But if you add on a double marker, you can pick up over 90% of your Downs. So in fact, if you're doing your nuchal translucency, nasal bone, ductus venosus and tricuspid Dopplers, which we will be hearing by Dr. Pratima soon, and we combine a double marker and everything is done in an accredited manner, you can pick up as high as 97% of Down syndrome without even putting in a needle, without doing an NIPT, nothing. So everything done at the right time in the right way will fetch us very high pickup rates. What is ideal? Beta HCG and PAPE, both should be 1 moms each. Now from tomorrow, I really wish that you all start reading your double marker reports rather than just reading the risks over them. Okay, because there is a lot more to than what the lab just tells us as low risk and high risk. Now let us come to the whole thing of the moms, but first the pattern of Down syndrome is that the HCG is going to be very high and the PAPE is going to be very low. So soon we will see cases where if you look at the moms, you will see that in cases where the HCG is high and the PAPE is low, the risk for Down syndrome will come as high. Whereas if HCG and PAPE both are extremely low, you will get a high risk for trisomy 13 and 18. There is nothing to remember in this. It's just a pattern. And when you see the double marker, you will also ascertain that yes, this is the way the risks come up. Now, just coming to what exactly moms mean in a very simplified manner, moms means multiples of median. And I take a step back here because I want you all to read only the moms on the report. Do not try and go to read beta HCG का value 2500 है, PAPE का value 127 है, ये normal है क्या? मुझे भी नहीं पता ये normal है क्या? Because I want to know the moms. So what are moms? Moms are what the value of beta HCG actually is and what it should be. That's it. So for example, at 12 weeks, the ideal PAPE value has to be 2800. But for this patient, it is 1400. So therefore, the mom is half because the patient's value of PAPE is half of what is actually required. This is very simplified and fortunately we don't have to do these calculations. The lab is going to give it to us. Now which means that agar kal se report mein hame PAPE 0.5 moms mila, it means that the PAPE of this particular double marker is actually half of how much it is actually supposed to be. Whereas if you find that the PAPE is 1.3 moms, it is 1.3 times of what it actually has to be. This is what the moms mean. And that's all you have to read on the report. You don't have to read the absolute values. And why don't you have to read the absolute values? Because the absolute values do not mean anything. What really matters is gestational age, how the double marker was done, what is the ethnicity, what is the weight of the lady, whether she was diabetic, whether there was twins. But you don't have to get into all this. You just have to fill a very nice requisition form for your double marker, because if you fill in any of this incorrect, your mom's calculation is going to be affected. So if you don't mention that this is an IVF, your mom's calculation is affected. If you don't mention whether this is a twins pregnancy or not, what is the chorionicity of the pregnancy, your moms are going to be incorrect. So remember, when you give a double marker report, when you give a double marker requisition, the amount of information on that form is all this. So from tomorrow, if your lab does not ask you these questions, either change the lab or at least suggest the lab to have accredited services, because all the genetic labs who are actually giving you correct double markers will ask you all these questions and they will not process the blood of the lady unless you have these answers. Okay, so it's very important to fill in a correct double marker requisition. So we'll go by this again. So now I have first taken a very normal report of double marker, and every day in OPD you find such women whom you have to counsel. So this is the kind of report, and it's very busy slide, and that's how the report looks. There are so many things on it, but come back to the moms. Can you see the corrected moms here? The free beta HCG, ignore the 67.8. It doesn't matter. What matters is 1.7. Okay. Now come back to the PAPE below there. Ignore the 624 absolute value. No, the lab has done all the background hard work and it's giving us a mom. So which is 0.2. Now what does this mean? Free beta HCG 1.7 means when ideal was 1, this lady actually has 1.7 times the HCG. And when the ideal PAPE was 1, this lady actually has 0.2 times. So it's really reduced, that PAPE. So this MOMS is giving us an idea that, okay, now this is a high HCG and this is a low PAPE. So this is how you read the report. You don't need to go into the concentrations. Okay. So what is really the labs done? They give us green and red colors. In a way, yes, it has simplified life. वो बड़े से पेपर में या तो 4 पेजेस के रिपोर्ट में अगर ग्रीन कलर दिख गया तो बस यू आर लो रिस्क, और अगर रेड कलर दिख गया तो probably refer to a fetal medicine specialist or the further doctor. But that's not it. Please try to read the numbers. Okay. I will just give you an example of how to read the numbers. Here the risk is very low for all the 3 aneuploidies. But how do you talk to the patient? 1 in 6,358. So what I would tell my patient is, तुम्ही काही टेस्ट नव्हती केली तेव्हा तुमचं रिस्क होतं 1 in 800. म्हणजे एक रूम मध्ये 800 लोक बसले होते तुमचे वयाचे आणि त्याच्यातलं एकाला मतिमंद बाळ होऊ शकलं असतं. But since you have done this screening, you have done the NT scan and the double marker, which has all come out to be very normal. आता तुम्हाला एक मोठे ग्राउंडवर पाठवलंय जिकडे तुमच्या सोबत 6,500 लोक आहे आणि आता तुम्ही त्याच्यातले एक झाले. सो तुम्हाला बरं वाटतंय क्या? अँड डेफिनेटली वेदर इट बी अ फार्मर और द CEO ऑफ द बिगेस्ट कंपनी, दे आर गोइंग टू अंडरस्टँड दिस एनॉलॉजी and they will realize that yes, now there are 6,500 people with me and I could be one of them. So yes, this is extremely low probability of me having a problem. So this is the way that you counsel about a double marker. Now I think we will come on to the cases. Okay, I really wish there was interaction, but all of those who want to I mean, not the experts, everybody's expert here. So I think the faculty link is different, right, ma'am? Yeah, okay, anyways. So the first case here, we have a 29-year-old, so she is young. She's got a previous child who's fine. She had an NT scan at 12 weeks and 3 days, which is the perfect time to do an NT scan. We'll soon see by Pratima ma'am about the scanning part of the 12 weeks. Now she has a CRL of 65, normal NT, normal nasal bone. So in fact, the scan is normal. And this is the double marker that has been given to us. Now, as I said, if we get a call saying that beta HCG 36.5 hai or PAPE 4.5 hai, I am really clueless as to what is happening. I want moms and therefore ignore the concentration and values. You can just skip it from your mind. Go on and move to the moms. Here you see beta HCG is 1.1 and the PAPE is 1. It's very close to 1, both of them. So it seems to be like a very, very low risk combined screening because everything seems to be ideal. And yes, that's what has happened. The age risk, without doing anything, what was her age risk? Because she's 29 years old, she got pregnant with a risk of 1 in 950. But because you've done such a beautiful screening for her and everything's come out to be normal, she has now moved on from a room of 950 people to a huge ground of 18,000 people, and her risk for having Down syndrome is extremely, extremely low. Okay? Now, this is the interpretation of a normal double marker. Now, let's come to the next case. The same lady who's 29 years old with a previous normal child, now comes back and she's now 13 weeks 6 days. Is she allowed to do an NT scan? Yes. Probably today is her last day when she can do the NT scan, right? Because the CRL is 84 and she's 13 weeks and 6 days. She did an NT scan. It was 12th of January and the NT was normal and the nasal bone was seen. Now she was told to give a double marker, but wo gaon chale gayi and she came back on 15th of January after 3 days celebrating a wedding. Now she is back and she gives the double marker report. So when she gives the double marker report, she is already 14 weeks and 3 days. The CRL is already more than 84 millimeters. So now what happens? The lab is confused. Number one, the lab should not have accepted the blood sample of a lady who has had an NT scan 3 days back, who was already 14 weeks then. Okay, that's the first thing. If the lab is accepting the blood sample, change the lab. Now, what next the lab did? The lab combined age, NT, and maternal serum proteins. I don't know what kind of combination that was, but she came out to be high risk. She came out to be 1 in 365, underwent so many tests, and which were all futile. Because just because you are doing a test, you cannot do it anytime. You need to do it at the right time. You should know how to interpret it. Yeah. So what should ideally have done in this situation? If she has not been able to give the double marker on the 12th of January, if she is coming back to you on 15th of January, the lab should have refused. She should have gone back to her gynecologist telling her that, look, sorry, I went to the village, I have not given my double marker. Don't just kind of sword her out, अरे बाप रे अब तो तुम्हारा बेबी पूरा abnormal हो जाएगा, तुमने double marker ही नहीं किया. It's okay. She's had an NT scan, that's fine. Tell her to give a quadruple marker at 16 weeks. Okay, quadruple is not as good as double, but it is fairly good enough in cases where you have missed the screening at 12 weeks. So instead of doing nothing or doing the test at the wrong time, tell her to give a quadruple marker at 16 weeks. And if that is low risk, that's the end of the story for her. Okay, so do not try to push in. Now, just another thing, it's not necessary to give the double marker on the same day as your NT scan. This is a huge misconception that a lot of us have. And if पूरा दिन डॉक्टर ने रुकाया, उनको बेबी फेस ही नहीं दिखा रहा था, उनको NT नहीं दिखा रहा था, मुझे रात हो गई, 8:30 हो गया, I have not been able to give double marker. Don't tell her that don't give the double marker. As long as she is less than 14 weeks, she can give the double marker. She should give the double marker, because an accredited lab is going to consider all those factors you remember on that page there: gestational age, when the scan was done, when the blood was given. So the mom's calculation of the double marker is going to depend on the date on which the scan was done and vis-a-vis the date on which the sample is given. So they will standardize it. So she could have had an NT scan on 1st of January, and she could still give the double marker on 5th of January, provided she is less than 14 weeks. It's very clear. Okay. There's never a wrong time to do the right thing. Well, this is a nice quote, but doesn't really apply to double marker again. So just because you're doing an amazing NT scan and double marker doesn't mean you can do it anytime. The moment you see a report like this, 11-week, ultrasound says CRL 38, NT normal, nasal bone normal, everything fine. Please call back the radiologist and say, look, please do not do an NT scan before 45 millimeters of CRL. Please call her back after 2 weeks and rescan her, because the whole process of NT validation can only take place between 45 millimeters and 84 millimeters. There is no two thoughts about it. So although technically you can do the NT scan between 45 and 84 millimeters, the best time to do it is between 60 and 70 millimeters, which is around 12 to 13 weeks. Okay, so please do not accept such NT scan reports where the CRL is less than 45 or more than 84 millimeters. Okay, now coming to the intermediate risk. This is something that has been troubling us nowadays, because labs have started reporting intermediate risk. And when we just got used to high risk and low risk, they introduced the intermediate risk. But there is a reason why they did that. And because it was found that these women who have intermediate risk are not really low risk. They do have an increased incidence of aneuploidy, and therefore we need to work about it. Now, this risk between 1 in 100 to 1 in 1000 is known as intermediate risk. So 1 in 55 is high risk. 1 in 2800 is low risk. But 1 in 400, 1 in 300, some of the labs will give you as low risk, but that's why you need to go and read the numbers. So from tomorrow, when you see that the lab has given a green line that it's low risk, but if it's showing 1 in 300, you need to dig harder and see why has the risk not improved. Okay, and the whole question there lies, Why has the risk not improved? Because the further plan is going to depend on that. Now, in this particular case, in front of us, you can, now I've just completely omitted the concentration and values because like I said, it doesn't matter. Go to the moms directly. Clearly, this lady has a high beta HCG and a low PAPE, and this is the reason why she has an intermediate risk of 1 in 405. Now, what to do about these intermediate risk? You toggle the ball between NIPT, amniocentesis, rescan, repeat a quadruple marker, repeat a double marker, do an ultrasound. There are so many options. Remember one rule of screening. Always step up the process of screening. Never keep doing the same things again and again. If as a fetal medicine person, I'm receiving a patient with NT 2.8 done 5 days back, if she is referred to me for a prominent NT, I am not going to sit and repeat her NT because the NT could have become 2.5 by now. NT is a measure of CRL. It changes with time. It can normalize even in normal babies. So I'm not going to sit here and tell her that, okay, now your NT is 2.5, matlab wo 3 din mein kam ho gaya hai, your baby is fine. No. I will prefer to step up my process of screening and do the next best thing that's possible. So when you have an intermediate double marker, you go back and see why her risk was intermediate. In this particular case, lady's age is 30. So she is not like a very elderly lady. Her NT is 1.2. You can read in these boxes, I hope. So just this one box has the 3 main things here: beta HCG, NT and PAPE. The NT is 1.2, which is absolutely normal. But because of her high HCG and low PAPE, she's come as intermediate risk. Now, revising again, how are we going to counsel her? Come down here on the risks area. Her age risk was 1 in 936, whereas now her final risk is 1 in 405. How will you counsel her? The same way like you counsel the low risk. So, तुम्ही काही टेस्ट न करता, जेव्हा तुम्ही 30 वयाला प्रेग्नेंट झाले, your risk for having a baby with Down syndrome was 1 in 900. So imagine yourself in a room of 900 people. You could be one of the babies. You could be one of them with a baby with Down syndrome. But now, after doing the sonography and the double marker, I have placed you in a smaller room with only 400 people, and now you are amongst one of them. Does that make you more comfortable or less comfortable? Less comfortable, because now there are less people with me. My probability of having a baby with a chromosomal abnormality has actually increased. And therefore, she will understand that, okay, भले ही वो लैब ने लो रिस्क लिखा है, पर ये एज रिस्क के हिसाब से रिस्क इंप्रूव नहीं हुआ है. And therefore, what are we going to do? In a situation where we have a combined screening, there is always a combined screening. There is no separate risk for NT scan, separate risk for double marker and separate combined risk. There is always only a combined screening risk. So once the risk is more than 100, so 1 in 60, 1 in 20, 1 in 25, go in and do an invasive testing. Don't try to find the middle path of doing NIPT, low risk hai to dekhte hain, scan karenge. 1 in 100 se zyada risk hai, please confirm whether the baby is normal. If the risk is better than 1 in 1000, if the risk is 1 in 4000, 5000, you leave her alone, she is low risk. The whole problem arises when she is intermediate risk. Now, when she is intermediate risk, the next question you ask yourself is the NT scan normal? Was it done at the right time? Was it done in an accredited way? Have you seen the images of that NT? If the ultrasound is normal and if the patient is happy with a 99% a surety about Downs, yes, NIPS is a good option. And once NIPS is low risk, you give her a routine standard of care. But if you ask yourself the question, ये intermediate risk का ये because इसका NT 2.8 है, NIPS is not the correct test to go ahead. Please go in and do an invasive testing. The simple reason, we'll come to NIPS, but I would like to reiterate this point twice. NIPS, very simplified, needs to be done when the ultrasound is normal. That's it. Because NIPS is going to be screening for Downs. Yes, it's an amazing screening, but it's best for Downs. It's not really going to come back to you with a very high detection rate of microdeletions and microduplications and other problems, and definitely not cardiac defects and structural defects. So if you have a high NT, if you have an absent nasal bone, ultrasound abnormalities, you prefer not doing an NIPT but to do a thorough ultrasound and an amniocentesis. Okay, so this is the approach towards an intermediate risk. We'll come back to NIPS and discuss this again. So coming to the next case here, she is an IVF conception, 12 weeks and 2 days. CRL is 65, NT scan is normal. Okay, now we look at the double marker. Again, forget the values. Come to the moms. Yeah, here we can see that the beta HCG is 5.6. So it's extremely high. It's 5 times what it should have been. And the PAPE is almost normal. Now, because of this high HCG, what has really happened is that she has come back as intermediate risk. So can we think harder here, or do we directly go in for NIPT? Well, yes, we could. But if you look at the history that I've given a hint there, she is an IVF conception. And we all know that although the HCG does not act, the HUCOG injections don't act till 12 weeks, because of a lot of high-risk mothers and IVF conceptions keep receiving bi-weekly and weekly HUCOG injections. So she's come to your OPD, you give her a HUCOG injection, okay, अभी बाहर जाके आप डबल मार्कर दे दो और फिर घर चले जाओ. You are administrating exogenous HCG and you are giving blood to do a beta HCG. It is going to come back to be high. It sounds really obvious, but it happens. It happens extremely commonly, and the IVF moms are already so worried about the whole pregnancy, and this adds on to the whole tension. So just a lesson to be taken from here. Please ask. So the accredited labs will ask, if you tick IVF conception, the next question they will ask is, was she on HCG injections? Did she take an injectable HCG within 3 days of giving the sample? If she has, then they will avoid taking the sample that day and give it later. So a safe thing to do is avoid giving double marker for 1 week after an HCG injection, although the plasma half-life is only 72 hours. But to be on a safer side, 1 week is a good time to space out your double marker sample and the HCG injection. So in this particular case, probably she would have come absolutely low risk if this injection was not given on the same day as her double marker. Coming to the next one, she's a 39-year-old. So now she is elderly. She's had previous one baby who's fine. Again, a normal NT scan. And you can look at the double marker here. The moms are excellent. They are 1.1 HCG and 1 PAPE. So almost ideal. Now the lab will come back to you saying that the age risk is high risk. Okay, वो age risk, high risk करके उसको bold करते हैं. कभी-कभी highlighter से भी also they will mark it, they will tick it, they will star it, and then the lady is confused and we all are confused. Now the age risk of 1 in 120 actually cannot be a high or low risk. The age risk is the risk with which she got pregnant. Because she is 39 years old, her age risk is 1 in 120. If she would have been 20 years old, her age risk would have been 1 in 1400. So age risk cannot be low or high. It depends on the age of the mother. So we get a lot of patients. So for example, now this lady has a very low risk after combination. But still she came to us for consultation because the lab said age risk is high risk, or usse there was a whole trigger of events. Okay, but actually speaking, her NT scan is normal, her double marker is fine, and she's come out to be 1 in 2300, which is a huge risk reduction. So from a room of 120 people before doing any other test, she's now reached a bigger room of 2300 people because her NT scan and double marker is actually normal. So this is a very, very normal situation. Now the last 2 cases, I think.
35 minutes done, Pujama.
Yes.
35 minutes are done.
Okay. Thank you so much. So this is now a 41-year-old lady, and she's doing the NT scan at the right time. The NT scan actually is normal. I have purposely kept all the NT scans as normal here so that variations in double marker can be worked on. Okay. Now she's an IVF conception, and you see that the NT is 1.2, the nasal bone is present. The beta HCG PAPE moms are beautiful. They are absolutely 1.1 and 1 again. Okay. So let's see how the risks come here. Her age risk is 1 in 80. Is it high, low? No, it's her age risk because she's 41 years old. Okay. Now, because everything was fine, she has moved from a room of 80 people to a room of 140 people. But is this a very convincing number? Are you very happy with that 1 in 140? Not really, because still she continues to be not very low risk. So what are we going to do here? I can't ask the delegates, but yes, there could be all kinds of answers. You could repeat a double marker, you could probably go in and do an NIPS. The moment IVF pregnancy comes, you do an NIPS. Okay? Fair enough. If the lady wants NIPS, don't do a double marker. We come to that discussion later. But in this situation, once you have opted to do a double marker, and if this kind of a situation comes, your first question in the mind is, how many IVF conceptions will really use their own oocytes to do an ovum pickup in the same year to have this pregnancy? So an accredited lab, once you tick that this is an IVF conception, when you're giving a requisition for double marker, will actually ask you, is it a donor oocyte or her own oocyte? Now, increasingly common frozen embryo transfers. So I routinely have these ladies who are actually 42 and 43 years old, have their own oocytes, but their ovum pickup was done 5 years back. My risk is hugely going to go down because I'm going to mention the date of ovum pickup. All these excellent genetic labs will ask you these questions because the risk of chromosomal abnormality will depend on the age of the oocyte when it was picked up, when the ovum pickup was done. So for this lady, either she is using a donor oocyte and the donor age will usually be less than 30 years, or she is using her own oocyte where her ovum pickup was actually done 5 or 8 years back or probably 3 years back, will change our whole risk and put her into a low risk category without doing any further risks. And these kind of complications and misinterpretations can be avoided if you fill in the correct form for double marker and if you send the labs to a correct lab. So ask for history of donor oocyte, donor embryo for all the IVF and ICSI conceptions. The risk of aneuploidy depends on the donor oocyte age and not the maternal age. Now, is it so straightforward? You look at the moms, you look at high risk, low risk, intermediate, scan and just divide. Or is there more read in between the lines? Well, there is a little bit more, but presuming that by now all of you are with me and you are going to jump to that box of HCG and PAPE, not ask about the concentration, immediately look at the moms and find out that the beta HCG actually looks okay with a mom of 0.96, but it is the PAPE that is 0.2 moms, which is extremely low. Okay, where I was expecting the PAPE to be 1 mom, it's 0.2 moms, and in spite of this lady being low risk, so 1 in 1400, 1 in 66,000 and 1 in 2,400. She is very low risk for all the aneuploidies, but I'm not going to ignore this low PAPE. So this baby may not have aneuploidies or chromosomal abnormalities, but what are the other associations of low PAPE? Now here comes the incentive for all of those who are feeling ki arey ये फीटल मेडिसिन वाले पिछले 10-15 साल से आके डाउन सिंड्रोम के बारे में बता रहे हैं, we have bigger problems to deal with. Now here comes your prediction of preeclampsia, your prediction of fetal growth restriction. If you go to any NICU today, you may really not find any micro deletions, duplications and downs, but all you will find is the IUGR babies, the babies born to preeclamptic mothers, the babies born too soon, and that is the chunk of the NICU. And probably if she would have had a double marker, she would have had a low PAPE on double marker. If you combine that with the maternal BMI, maternal age, history of recurrent losses, the uterine artery pulsatility index, you can predict preeclampsia, fetal growth restriction to a tune of 90%, especially the early and severe ones. So when you are really doing double marker, you are not just doing it for chromosomal abnormalities. You are looking beyond chromosomal abnormalities. You are looking at adverse obstetric outcomes for the mother, for the baby. So a low PAPE, especially less than 0.4 moms, is significantly associated with spontaneous fetal loss less than 24 weeks, higher risk of preeclampsia in the mother, higher risk of fetal growth restriction, higher risk of preterm birth, and rare syndromic associations which could not probably be picked up by NIPT. So a lot of times when I see a patient for the first time at 32 weeks and there is severe FGR and it's a young lady, not obese, everything is fine, and everybody is wondering what is the reason for this FGR going on, especially when the structures are fine and everything else seems okay. You go back to the double marker, it was low risk, but if you go to the papillae, invariably you will find these low. So the low papae is really an ominous sign, and especially less than 0.4 moms, you got to see these mothers and babies more frequently than the ones with a normal papae. So this is the importance of doing a maternal biochemistry or a double marker beyond aneuploidies, beyond the chromosomal problems. Now, another issue is that some practical problems that we face, especially in our country, is that you could argue that the lady is not even convinced for an NT scan. We are trying to convince her to do an NT scan, but probably double marker is really far-fetched because it becomes too expensive. If you give an incentive to the mother that a lot of problems of your pregnancy are going to be predicted by doing this double marker, and if you all from a particular village, town or city, hospital, institution start sending double markers to an accredited genetic lab, the increase in number of volumes of samples will bring down the costs hugely. So I am associated with Ruby Hall, which is really posh. They can all afford NIPS, but I'm also, I have 2 students under me at Bharati Vidyapeeth, which is a teaching hospital, and the women are really not convinced about doing anything there. But for the last 6 years, we've got more than 95% turnout rate for double marker. After we have started sending more number of samples, the rate has come down from 3,000 rupees in 2016 to 800 and 700 rupees today, only because we are sending more volumes to them. So please be convinced yourself that the double marker is going to be helpful. Only then you can convince the patient to actually go ahead and do it. So this is the reason why we can't choose whom to do double marker and whom not. Now, first trimester screening for vanishing twins. Now, a lot of times, especially with this IVF and ICSI going on, we start off with the twins and then one of them vanishes off at 7-8 weeks and only a single baby is left till the NT scan. So what are the rules for that? We have excellent guidelines in 2022 which say that if a detectable non-viable embryo is seen on NT scan, so you are doing an NT scan, there is a good baby, there is another vanishing twin where you can measure a CRL, please avoid double marker, because the dead tissue is going to release, is going to cause a falsely higher papae, and a false higher papae may cause a false negative Down syndrome result for the ongoing baby, because higher the papae, better the risks. And here it's a pseudo high papae. So to avoid all these things, another thing, the good lab will always look at your last scan report before taking the sample. A lot of times the lab actually calls us, ki doctor, you've written double marker, but you've reported that there is a 23 millimeter CRL non-viable gestation along with a good baby. We cannot take the double marker in this situation. This is the kind of lab you need to send your samples to. Okay, so if detectable dead embryo is seen on scan, NT scan alone needs to be done, and do not combine it with a double marker. In vanishing twin happening less than 12 weeks, the quadruple is not altered. So you can actually go ahead and give a quadruple marker in such situations. Now, embryo reduction is becoming increasingly common, and if you are reducing twins to singleton, before reduction, give her double marker. Okay, give your double marker, then do the NT scan, you get the double marker reports by then, and then do the reduction. Because once you do a reduction, it's going to be really difficult to again send maternal biochemistry. Now, suppose that she is an elderly lady and she's got twins. You've reduced twins to singleton. After 8 weeks of reduction, you can go in and give an NIPS. So, NIPS can be given in a twins to singleton after 8 weeks of demise, whether it is by embryo reduction or a vanishing twin. Okay, labs are not accepting NIPS for triplets to twins. So in triplets, practically speaking, you will have to go by your scan again. Yeah, and never ever try to go in and do a quadruple marker after doing a fetal reduction at 12-13 weeks, because invariably the AFP is going to be high and she's going to come back with a high risk for neural tube defects, and you will keep looking what the problem was. The problem is that the dead baby is releasing all the AFP and causing a pseudo high risk. Okay, so to simplify again, at NT scan, you see a single baby, you give the double marker. At NT scan, you see a single baby with an empty sac and a non-measurable CRL embryo. Past history of vanishing twin, you can still give the double marker because the embryo is not measurable. Third situation, you are seeing twins, one vanishing twin, you can measure that baby, don't give the double marker, wait to give the quadruple marker. Okay, so this is how you deal with the multiple pregnancies. Now, when not to do a test is equally important. If you find that the NT is 3.5, the absent nasal bone, and there is tricuspid regurgitation, or there is any gross abnormality on ultrasound, please refrain from giving a double marker blood sample, because more likely that this lady is actually going to require an invasive later. And please do not do a double marker and try to fit her into a normal situation. Anything more than 13 weeks, 6 days, and less than 15 weeks, please do not give any. So practically nothing can be done between 14 and 16 weeks except NIPS, will come to that. But quadruple and double markers not to be done between 14 and 16 weeks. Double marker to be done between 11 to 13 plus 6, and quadruple preferably to be done after 15 to 16 weeks. Okay. Now, if there is a history of single gene disorder, or you're going to do a CVS for thalassemia, or you're going to do an amniocentesis for sickle cell, or any other single gene defect, then you can really talk to the couple that you are any which way going to put in a needle to do an invasive. Let us do a karyotype or a microarray along with that test to get 100% assurance about chromosomes of the baby. And more often than not, the couples will agree to doing this test. So if you are any which way planning a karyotype or a microarray, because you're going to do an invasive for any other reason, you please skip the double marker. Then you don't need to do both. Okay. Fresh, ongoing, large bleeds on scan, avoid doing a double marker. Fetal reduction, we've already spoken about this. So these are reasons where you don't do a double marker. Now coming to all our favorite topic, NIPS. We love doing the test. We like to do it anytime.
I'm sorry to interrupt you. Pooja ma'am, I'm so sorry to interrupt you.
No
we
problem.
have time constraint on this platform.
Okay, so
and we
just
have
one
more
last. Actually, now I didn't see the number of minutes allotted to a speaker, so I didn't know how much to speak. But I'll come to the last slide and the message I want to give everyone. The only indication for doing an NIPS is when the ultrasound is normal, but you can do it with an advanced maternal age. If she is high risk because of double marker, if there is a history of prior Down syndrome baby, or any other high risk situation where the ultrasound is normal. So this is the only slide I wanted to highlight in NIPT, and that brings us to the last slide of today's presentation. So beauty lies in originality, but change is the only constant. Technology is a boon when used judiciously in aptly indicated cases, with proper interpretation, without compromising on what is inevitable. NT scan, NT scan, NT scan, and then come on to double marker. Thank you so much, and really sorry if I overshot the time. I didn't know the time, ma'am. Thank you so much.
Thank you, Dr. Pooja. That was an excellent lecture, stressing on the importance of universal screening. That is, every pregnant mother should be screened, and clearing the concepts of moms, and how to read the fine prints, just not look at the risk alone. So look at the other moms as well, and also stressing on the other uses of doing a double marker, other than aneuploidy screening. It was very nice. Thank you.
Thank you, respected
Dr. Pooja.
madam. Thank you, Dr.
for
Pooja. And I would like to inform to the House that Dr. Usha Madam will be with us for next webinar on next Thursday also. And it's a great honor for us. Thank you, Madam.
Thank you.
Sujit sir, your comment, please.
Yeah, that has been a very excellent talk. Everything has been clearly and simple, told in a very simple language. So just one question, is there any value of high PAPE?
Not known so far, sir.
Dr. Sujit, what was the question? Please repeat once again.
Is there any value of high PAPE? We're discussing
High
very much
PAPE.
about low PAPE,
Yeah.
low PAPE,
Okay.
high PAPE.
Hi-
Is it
high-
associated with macrosomia?
Associated with?
Macrosomia, no.
There was a study
Yeah.
around 5
Yes.
years back when the PAPE new came in that lower the PAPE, less is the fetal weight, higher the PAPE, more is the fetal weight. There have not been larger studies to substantiate that yet. And
I heard
gene
somewhere.
screening continues to be the only way to predict macrosomia.
I have read somewhere, that's why I asked. Okay. Anything you want to add, Subhuhi?
No, it's fine. It's just that I should be able to deliver my talk well. I think I'm
Yeah, be prepared.
kind of exhausted.
Yeah, now let's move to next session.
So after this wonderful talk, let's move to the next session. That is evaluating the twins in first trimester. So we have esteemed speaker, Dr. Subhuhi Rizvi ma'am, and respected chairpersons, Dr. James P.O. and Dr. Sujamma ma'am. So can I have the CV of chairpersons?
Bhavna, please do the needful.
Yeah. So I'm privileged to introduce Dr. P.O. James, sir. Sir is consultant, maternal fetal medicine unit, child development center, and SAT hospital, GMC Trivandrum, Kerala. He is assistant professor, GMC Trivandrum, Kerala. He has done FMB in high risk obstetrics and perinatology from Fernandez Hospital, Hyderabad. He has done postdoctoral fellowship in fetal medicine from Mediscan Systems. His area of interest are labor ward protocols, maternal medical disorders, multiple pregnancies, and fetal growth disorders. I welcome you, sir.
Yeah, thank you, ma'am.
Yeah. So our next esteemed, respected chairperson is Dr. Sujammo Jacob, ma'am. She is professor and head at Department of OBGYN at SAT Hospital, GMC Trivandrum. She has specialization in high-risk obstetrics, ultrasound and Doppler and vaginal surgeries. She has been the president of TROGS, past secretary of the TROGS, postgraduate examiner of MD/MS, DNB, FMB, KHS inspector for medical colleges, and she has publications in national and international journals to her academic credit. So I welcome you, ma'am. So I would like to request our chairperson to please introduce our speaker. Dr. James, sir.
Yeah. I thank the association. First of all, let me thank the Association of Maharashtra Society. Can you hear me, madam? Am I audible?
Yes, sir. Yes, sir. Pretty well.
Yeah, I thank the Association of Maharashtra Society of Obstetrics and Gynecology for this platform to chair this session. Without delaying the webinar, let me take this opportunity to introduce the next speaker, Dr. Subhuhi Rizvi. Madam will be presenting on a very important topic, that is first trimester evaluation of twins. And Madam is the director of Mother's Clinic and Ultrasound Center since 20 years, based in Gurgaon. She is fetal medicine. She has a certification from Fetal Medicine Foundation UK in fetal medicine. She has done her advances in fetal medicine course, London, UK. She is vice president, Gurgaon Obstetrics and Gynecology Society. Since more than 25 years, she has the post PGS experience, and she has a lot of paper presentations and been a faculty in national level conferences. She has poster presentations and annual conferences in Japan Society of Obstetrics and Gynecology. She has started Heal India program for adolescents and their parents, and she's been member of a lot of societies. I can see she is a member of Fetal Medicine Foundation, Society of Fetal Medicine, International Society of Ultrasound in Obstetrics and Gynecology, and Silver Society of India. Over to you, madam, for the lecture.
Good evening. And first of all, I thank the universe for this opportunity. Excellent opportunity with excellent chairpersons. And I think all the other speakers are very good. I thank Dr. Sujit. You are my friend, and that is why I think you have called me here. And Dr. Rashmi, Thank you so much for inviting me. I think it's just few days back you called me and you told me, okay, take out any presentation and present. But as I don't like feeding the people with the basi food, I don't like giving the basi presentation for my presentation. So I prepared a new food, and I hope that I'll be crisp, and I have taken some gems, but I'll be learning more from the esteemed chairpersons also on this. So that is their, that's all. So can I just share my screen? If you can help me. Yeah. So you can share, you can see the screen?
Yes, yes, yes.
So this evaluation of twin pregnancy is one of the things that I keep getting very often, because some of my friends are infertility specialists and they find me good with the patients. And so I thought that this is something that makes me excited, especially when I'm going to close my OPD and patient come with twin pregnancy. So you just have to sit, relax, and do the scan. There are diagnostic challenges and limitations, which I'll be covering, and I'll try to make it in 20 minutes, and that is the time allotted to me, Rashmi. Dr. Rashmi, if I'm right on that. So when I started my clinic here in Gurgaon 20 years back, I realized that a lot of females are not informed and not educated. So money is not a problem in Gurgaon, but lack of education and awareness is one of the problems. And that is why I do a lot of awareness workshops on different subjects, because healthy women meet healthy India. So I am Dr. Subuhi, and I like doing my fetal scans. And I've been trying to do a lot of courses for the sharpening my axe, actually. And I also conduct hands-on training program for PG students in different medical colleges. That is a kind of payback for in the memory of my father. And that is what I go and do. And I love doing that. And of course, going into international conferences makes me more humble. And that is one of the things that I wanted to say. So all of us have talents. And yes, many times young people stay away from presenting papers because they think there are a lot of good and very talented people present, but everybody has a song, and the talent is to sing your song well. And here I am with my song. So why am I looking into a subject or a topic that needed many hours of my studying, and still I'm not like having very concrete answers to many things? Because over a period of time, we have seen that females are marrying late. They are not marrying early because of their professional commitments and many other things. And ART is blooming. And I don't know how many centers Maharashtra has, but Gurgaon itself has around 70 centers, which are IVF centers here. So very often we get patients who are having twin pregnancy with advanced maternal age. So that doubles up the kind of investigations I do. Of course, chorionsity is the main determinant, and it is best seen in the first trimester. So that is why I feel that, and if any time you get the patient in second trimester, you have to go back and see where the first ultrasound was done and see if you can see the membrane. If it is not even mentioned there, it is better that you just go and see. Of course, these twin pregnancies are high-risk pregnancy, and early ultrasound, it's actually very crucial in the management of complications later on also. So what are the types of twin pregnancy? It is just a revision, but actually it makes me every time very, very important to start the talk with this. We know that most of the twin pregnancy are dizygotic, but 25 to 30 are monozygotic. Now, these monozygotic pregnancies can be like dichorionic also. So that is important. So we know that zygosity will let me assess the risk of the genetic disease, and chorionsity is important for our follow-up and assessment of perinatal complications. So in the first trimester, just before 14 weeks, it is very, very important for us to see both the pregnancy, see the membrane, and assess this thing. Now, this is a very interesting slide. I don't know whether it should have been included, but I found it very cute and useful here. That how, if in a monochorionic twin also, if it is like an early division, we can have dichorionic diamniotic pregnancy, which is there in 25% cases. But if it is like 4 to 8 days, then it can be monochorionic diamniotic, and I think that is very commonly seen. Now, 9 to 12 days, if it is implanted, if the implanted blastocyst divides, then it's good monochorionic monoamniotic, and that is not the pregnancy we love, because we have to do very close investigations and observations in this. And of course, conjoined twins are very, very rare, less than 1% or more, but still it's there because of monochorionic twin. So whenever we are talking about a subject, we are talking because we want to know, we want to understand that how we can understand the complications there. And we know that the complication of twin pregnancy can be vanishing twins, as it was described by Dr. Pooja also. And of course, all the time, whenever a twin pregnancy comes, all the obstetricians are very much scared of prematurity, because it is one of the most common complications of twin pregnancy. Of course, there are other complications that happen, like twin-to-twin transfusion syndrome. That is, again, a very typical of monochorionic pregnancy. And then twin anemia, polycythemia syndrome, or TRAP. So these are the percentages which I've given. And of course, there are for fetal growth restriction and intrauterine fetal deaths. The complications are important for us to understand, so that whenever we get a twin pregnancy, and when we are very happy to see a twin pregnancy also, we should understand that when this patient should be referred to a fetal medicine expert. Of course, there are discordant anomalies with the twin pregnancy. More than 80%, regardless of the chorionicity, are affected with discordant anomaly. Like one twin will have an anomaly and the other will not have an anomaly. And that is a very difficult situation for the obstetricians and the fetal medicine experts. Dichorionic twins carry 2 times higher risk, because of course they are having 2 single pregnancies. So the risk is 2 times. And then the monochorionic twin increases the risk of each fetus as the process is post-zygotic. So in the monochorionic twins, the risk is 2 to 3 times higher. Then, of course, the chromosomal anomaly risk is again increased. In dichorionic twins, it's 2 times higher as compared to singleton. And in monochorionic, the risk is same as a singleton, as both fetuses are in one pair. But in some cases, when there are heterokaryotypic fetuses, then the risk is more. In the fetal and perinatal death, they're 2 to 3 times higher than the dichorionic twins, and 5 to 6 times higher in mono. So these deaths can occur more commonly in monochorionic death. Now, whenever I get a patient of twin pregnancy, I try to maximize what I can see in the first scan itself, even if it is an early scan. And I see, of course, we measure the CRL in both the things. And whenever the patient is coming with an early pregnancy also, you have to see the history of an IVF, if it's an IVF pregnancy. Then there is a calculator of perinatology.com, see the date of the embryo transfer, if it is 3rd day and 5th day, and accordingly you can assign and understand the expected date of delivery. See the bigger CRL and the smaller CRL, both the cases, and accordingly we will see, because the LMP will not matter in such cases, otherwise also you have to see. Now, try to gather as much information as you can in the first visit itself. Don't wait for the level 1 scan. We'll be coming to that. But whenever a first patient comes with early pregnancy, maybe 8 weeks, 5 days also, you assign, okay, this is a lower or that one is a higher, and see which fetus is having, because the discordance can arise very early also. So try to see as much as you can in the first visit itself. Now, these are the 2 things, like how you can differentiate a dichorionic, diamniotic pregnancy from a monochorionic and diamniotic pregnancy. Lambda sign, that is very, very clearly seen in the first trimester. You have to see that, of course, whenever you see a lambda sign, you be assured that it's a dichorionic, diamniotic. The complications will be lesser in such cases. And a monochorionic, you have a thin membrane, and that's a T sign. And these pictures I've taken from the Alfred Rabi Chow's book. So sometimes the membrane is not visible. Then don't understand that it is a monochorionic twin, because many times it can be, it has to be ruled out that it is a TTS, and the one small twin can be just stuck to the wall and it's not seen. So even if you are not seeing the membrane, understand that it cannot be just labeled as a monoamniotic pregnancy only. Okay. So chorionicity matters because it determines the risk, and it's the follow-up, as well as many of the other investigations which we'll be doing later on in calculating the risk. And you have to see that this kind of lambda sign is seen, so that you are very sure about the chorionicity. Now, in some cases, when you see there is intertwined membrane is there, and you pull the cord entanglement, you can see. You put a color Doppler and see that there are two peaks in the, see the 2 umbilical cord peaks you are seeing. In such cases, it is universally seen in monoamniotic pregnancy. So when you don't have a dividing membrane, so the cord entangle, and then you put the color Doppler, and you can see this is a monoamniotic pregnancy, and it's around 100% diagnostic of that. So first trimester is a golden opportunity to evaluate the twin pregnancy. But as we say in the literature that, okay, calculate the CRL and then you see which is the what fetus and then you see when there is a discordancy. But is it that simple every time whenever you are seeing? Because when you are seeing, the fetus are not sitting there for you to take the CRL. So they keep jumping. And when they keep jumping, it is not always easy to measure the CRL. So what you can do is that, let's just see. I'll say when the fetus settles, take a proper CRL is a must whenever you are evaluating a pregnancy in the first trimester. Because if you are not taking the CRL in the first trimester properly and not labeling the twins in the first trimester, it will be very difficult for the doctor to assess and for other management protocols. So once you see the CRL, and if you see that the CRL discordance between the two twins is more than 10 or more than 15%, then the risk of adverse outcome in monochorionic dichorionic pregnancies can be very much. Then fetal death and fetal loss is less than 24 weeks. And then preterm delivery risk increases, and chromosomal and structural abnormalities are also increased if the discordance is more than 10 to 15%. Now, what if you get a fetus and then you see, okay, I'm going to measure a CRL, and you start doing the things, the ultrasound scan, but both the fetuses are not settling, like they are keep moving, and you are actually not able to get the CRL. In that case, when you are not able to see the CRL first, do the next best thing. Instead of wasting time, see whether you can evaluate and see the 4 chambers of the heart, see the membranes if you can see, count the limbs of both the fetuses, because time is important for you. So many times, like it keeps on jumping. So if you can see the cardiac chambers properly, note down that, so that it takes away and decreases the time when you can evaluate the CRL. Next time is that you have to see the NT, and I think Dr. Pooja clearly mentioned it, that NT is one thing that we need to measure very properly. Now, NT, many times when you measure in twin pregnancy, the zygomatic bone comes in between. So in such cases, what I believe is doing is that take a small clip of the NT, and then you can just clearly see if it can slowly and evaluate where is the nasal bone and how much is the NT, and how you can just take a picture without a zygomatic bone. So take time to see NT, and that is very, very important in this case. Now, what other thing is important is that whenever you see twin pregnancies in the first trimester, don't miss the other markers. Like NT you have seen, nasal bone you have seen, but it is a beautiful opportunity to see other markers like ductus venosus, umbilical vessels, and you can actually clearly see if you sit patiently with the patient and see the fetuses and love the fetus. So that is important, that ductus venosus can be very easily seen, umbilical can be very easily seen, but limbs can be seen, tricuspid regurgitation if you are actually into it. So most of the markers can be easily seen, and you should be very clear about that. Now, what is the labeling? Like whenever you get a fetus in the first trimester, it is very important to label it. So you have to follow a descriptive process. It cannot be just said it's a lower sac or it's an upper sac. You have to label it whether it's lower and upper, and on which maternal side is that. Like if you can say that upper sac, which is towards the right of the maternal line, is this. The fetus A is on the upper side, right of the maternal sac, and the placenta you are seeing there, and the cord insertion is there. So you can have to have a descriptive process to label the baby, so that it can be easily interpreted by you yourself next time when the patient comes. Because many times, if you're not able to label that baby, and next time the patient comes for the second trimester scan, you yourself will be confused. So the first trimester, by 13 weeks, you should be, by 14 weeks also, you should be able to label the fetus very clearly and have a follow a descriptive process, not just like, okay, fetus A is that, fetus B is that. No, that is not the report. Where is fetus A? You have to, in relation to maternal side, as well as whether it's upper, lower, left side. So these things are very important for us. Now, prediction of preterm birth is again a very, very important thing. We know that the twin pregnancy is because of n number of reasons very much predisposed to preterm birth. And the idea is to prolong the pregnancy as much as we can, so that the twin fetus does not have the need to go for a nursery. So as cervical length is used in singleton pregnancies, it is also used in twin pregnancy, and you see that it's like after 24 weeks, sudden shortening of the cervix happens. So you can have a serial way of monitoring the cervix also. I do it in my clinic from the first trimester itself. I measure the cervical length as well as I see how it's behaving, whether it's well curved or linear. Many times, if it is not well curved, then the chances are there. So they see in the graph, you see that how it decreases and how the risk of preterm birth increases. So that is the thing that I wanted to say. Now, about the other thing is that about coming to the biochemical markers, and I think Dr. Pooja explained in a very good way, but still we have to understand that it is not easy to interpret biochemical markers in the twin pregnancy because they're typically elevated in twins, and they complicate the interpretation if the lab is not actually following a proper kind of module to interpret the twin pregnancy results. So calculating individual risk in twin pregnancies more complex. So there are challenges like this. And the type of twin also matters, like whether it's a monozygotic or a dizygotic twin, and then it affects the markers. And then there are number of high false positive results in that. So we have already seen and discussed about it, that how a combined screening is very effective. As was common in dichorionic twins, you can actually calculate the risk of individual fetuses. You have to combine how PAP and beta HCG and with maternal age, ethnicity, whether it's an IVF pregnancy or it's a normal pregnancy. See the nuchal transitory ductus and nasal bone, and when you combine that, then you can actually specifically calculate the individual fetus risk in dichorionic pregnancy. So they have the special algorithms for this calculation, and that is again a very important and a good thing. And of course, we have discussed about NIPT also, that it remains one of the good measures, but the false positive rates or absence, there can be cases in which you don't get a good fetal fraction in dichorionic twin pregnancy, and that is one of the things that can happen because in the NIPT factors. So how do you follow up? And this is important for us to understand. And I think most of the people know that in dichorionic twin pregnancy, after 18 to 20 weeks, a 4-weekly follow-up can be done. And in monochorionic, more like 2-weekly follow-up has to be done. And you have to see fetal biometry, AFI, Doppler ultrasound, and MCA. And if there is any complication, then you have to see that you have to really refer the patient to maternal and fetal specialist unit. In the same time, when we are managing twins, we have to be very much bothered about maternal health. And that is important to see how the blood pressure is there, because of course, the chances of preeclampsia are very much increased in cases of twin pregnancy. The Barcelona guidelines suggest that we have to, and normally we do start ecosprin 150 milligram in most patients of twin pregnancy. Blood sugar assessment is again very common, and the overall well-being of the patient is very important for us to understand. Now, monitoring, what actually we can see whether there is fetal growth restriction. Whenever we are monitoring, we can see if there is discrepancy that is increasing, or if the amniotic fluid is increasing in one or decreasing in the, we can see the bladder size, and of course the biometry. If there is a difference, then we can see that whether there's an inter-twin discordance that is developing. And of course, there can be early diagnosis of TAPS, and then customized fetal growth charts are available for twin pregnancy, which are very important for us to see. Early diagnosis of TTTS is important, and very early in the pregnancy, maybe 13 to 14 weeks also, fetal echo should be started in monochorionic twins, and maybe by 16 weeks in dichorionic twins if it is there. And if you feel that the patient is having other complications, then you can start fetal echo very early, because that is very important. So we have seen, to conclude, that there is increase in twin pregnancy over these years, and because of late marriages and increased ART. First trimester is a golden opportunity. We have to determine the chorionicity and the amnionicity. And the multidisciplinary approach is one thing that is always very important in twin pregnancy. And biochemical screening needs careful interpretation, and fetal medicine referral is of utmost importance. And this is my patient, which I saw the first slide, and I took her permission to post this. We know that I was asking that I go to write an article on the difficulties faced post-delivery. So she gave me a very nice write-up. We know that we can increase, they have the twice the smile, twice the laughter, twice the love, and being a mother of twin is truly a double blessing. But they all say that it is very difficult to manage 2 patients without much help, 2 babies without help. So let's make their journey beautiful. And I'm Subuhi, and these are the references I consulted. Thank you so much.
So please unmute yourself.
Yes, ma'am. Yeah. So, thank you, Dr. Risvi. To summarize, it was a good presentation, Dr.
Thank you,
Risvi.
sir.
To summarize, I would like to say the importance of first trimester evaluation of twins. The first thing is we have to look at the number of fetuses, look at the number of look at the membranes in between the fetuses, look at the membrane insertions, look at the chorionicity, look at the amnionicity. Twin nomenclature is important because it should not be changed in further scans. And accurate dating is very, very important because we are going to deliver them a little earlier sometimes. So an accurate dating is very important. A first trimester target scan is very important for twins to rule out definitely seen anomalies in the first trimester, or at least to rule out possibly seen anomalies in the first trimester, because these twins carry a higher risk for congenital anomalies. So first trimester target scan at 11 to 14 weeks is very important in a twin pregnancy. Of course, you will be looking at the aneuploid markers. That is a primary marker being the NT, and the adjuvant markers, if we are trained, you have to look at the tricuspid revegetation, ductus venosus, and the unossified nasal bone. Now, we may be able to predict adverse outcome in the monochorionics even in the first trimester by looking at the NT discordancy if it is more than 20%, CRL discordancy if it is more than 10%, or even looking at the discordance in the attachment of the cord insertions. We may be able to predict subsequent development of complications of monochorionics like TTTS or selective fetal growth restriction. Now, being twin pregnancy, it can be an IVF pregnancy. So look at the adnexa for heterotrophic pregnancy or an evidence of any hyperstimulation, because a number of mothers would have undergone IVF treatments also. Look at the transvaginal cervical length. And very important, after doing a scan, you have to do a counseling and explaining the options of aneuploidy screening. Now, multiple pregnancy is the highest pregnancy. At the end of the first trimester evaluation, sit with the couple and counsel them that what is the chorionicity, significance of chorionicity, because this will make them understand that they have to be monitored very frequently, more than a singleton pregnancy, and what they are going to expect in few of the pregnancy complications in the subsequent evaluation. Also look at the maternal risk factors. Maternal risk factors of venous thromboembolism, and if needed, institute from VTE prophylaxis. That is very important. And the Barcelona people, if it becomes a twin pregnancy, they just empirically start on ecosprin 150 milligram. Yeah. So we do that in our institute. We start ecosprin for all mothers who have a multiple pregnancy. Now, if you have a luxury, last but not least, I want to tell you, if you have a luxury of a trained person evaluating twins around you, just please send it across to them for a proper first trimester evaluation of a twin pregnancy, because it will help you in a big way in subsequent evaluations. Because it's the most common problem we encounter is, you don't have a proper evaluation in the first trimester and they just come at 20 weeks and you have to start it from the beginning, and you are nowhere. Sometimes you will be nowhere. So if you have a trained person or a fetal medicine specialist around, if you have a twin pregnancy, just send it to them across. They will categorize them and they will give you back, give them back to you. Okay. Yeah, this is what I would like to tell.
Thank you.
Very
Thank you,
good
sir.
presentation.
Jamal ma'am. Madam, are you there?
Yeah, definitely. That's a very clear presentation, basic presentation on the twins. In fact, James has also told about the feedback regarding the twin gestation, how it has to be clearly evaluated in the first trimester itself, the importance of chorionicity. And one thing is, suppose we are not able to clearly see or evaluate the chorionicity, I think it's better you consider it as a monochorionic. Is it? Or rather, we are not able to very clearly say in terms. Is it to consider it as a monochorionic rather than a dichorionic for all practical purposes? That is one point. Then about the labeling, ideally you take more than one aspect for the labeling.
Yeah.
if it is a fetus which is on the right and the left or the upper and below, and also regarding the placental attachment, if it's anterior and posterior.
Yes.
Then about the cord insertions, one placenta it's a central and the other is a periphery. That all these points taken together, we can make a cord, we can make a labeling. Otherwise, there is something called as a perinatal switch phenomenon, wherein the first baby will come out second, or when you follow up the babies with a selective growth restriction and all that.
Exactly.
These are some of the points I would like, and also the discordancy, which James has also mentioned. Suppose the CRL discordancy of more than 10% or an NT of more than 20%, that may be an early pointer towards the development of TTTS and other anomalies. So we have to be on the lookout for these anomalies in subsequent scans. Anyway, it was a very clear presentation. Very nice presentation, Dr.
Thank you,
Subodhi.
ma'am. Thank you so much.
Thank you.
I think.
Thank you.
Yeah, I was.
Thank you, respected Dr. Sujamal Madam and Dr. James Sir and Dr. Subui Madam. Thank you so much for all the valuable inputs. This was a very great session. Thank you so much.
Thank you, ma'am.
Any questions, Jaya?
It was a wonderful session, ma'am, as usual. Subodhi, ma'am.
Thank you so much. I'm not ma'am, I'm just Dr. Subui.
So let's move
way
to the
become a ma'am. Yes. Dr. Sujit, you did not say anything. I prepared it for you.
No, it has been, everything is clear very nicely, and chairperson commented very nicely. So no scope of any additional comments.
Thank you so much. Like,
it was excellent, very excellent presentation.
It was fine, I guess. Thank you so much.
Thank you.
They start progesterone also. Say, do you start progesterone routinely if you see that 2.5 centimeter is like the cervix is less than 2.5 centimeters? All of you start progesterone like we do here in Gurgaon. We start progesterone if the cervical length is less than 2.5 centimeters.
Yeah.
James,
Surely.
Yeah, that's there. Okay, because I think circlage they have just given. Barcelona people have just told circlage in one situation when it is less than 1 centimeter. So that is there. Otherwise, they have said that progesterone 400 milligram to be given if it is less than 2.5 centimeters. Thank you so much.
Okay, thank you, Dr. Subui. Really very excellent presentation. I think with this we can, Madam, can we start session 3? Yeah. Okay, so for session 3, our speaker is our own Dr. Pratima Radhakrishnan ma'am, and chairpersons are Dr. Nagaratna Kuntoji, President of Balakot OBGY Society, and Dr. Sumaya Firdos Patel, Consultant Obstetrics and Gynecology. So can I get their CVs, please? Dr. Nagaratna Kuntoji, she is President of Balakot OBGY Society. Her areas of interest are high-risk pregnancy and social obstetrics. And credits to her is organizing secretary of KSOGA, and 2018 organized several CMEs and workshops, chaired several conferences, several publications in national and international conferences. We welcome you, madam. Next. Dr. Sumaya Firdos Patel, Madam is MBBS DGO, Consultant Obstetrician and Gynecologist. She's Medical Director of City Hospital, Belagavi, and President of Belagavi Obstetrics and Gynecology Society, Joint Secretary of Indian Menopause Society, Belgium and Chapter. Areas of interest is high-risk obstetrics and menopause. Welcome, madam. Welcome. I welcome all the chairpersons, and I request them to invite our speaker, please. Thank you.
Thank you very much for the opportunity. It's my pleasure to introduce to you today's speaker, Dr. Pratima Radhakrishnan Madam. She is a very distinguished faculty. She was one of the first to perform therapeutic fetoscopic laser in India. She is the first to, she has many firsts to her credit, by the way. And she's also the first to start online and on-site distance learning blended courses in fetal ultrasound, which has benefited several doctors across the country. And her special interests are fetal diagnosis and therapy, early fetal screening diagnosis. She is also an educationalist. and she conducts fellowships online and on-site distance learning programs. And her flagship program is fetal ultrasound program and gynec ultrasound program. And she has many orations to her credit, like the Banu Koyaji oration, the Shirodkar oration, and also the Parangi orations at Mahabaleshwar. And she's also given the keynote address at Hubli in 2015 and Mumbai in 2018. And she has many awards to her credit. And she's conducted several fetal invasive procedures. And she invasive procedures, and she is also a recipient of Mohinder Kochar Award, which for best presentation, and she has successfully done many fetal invasive procedures, and she is one of the very esteemed faculty as far as first trimester screening is concerned. It is indeed my pleasure to introduce you, madam, and over to you now for your talk. Thank you.
Dr. Sumaya. First of all, I must thank AMOC Society, and I really love the way you, Jagrati, you said our own. I feel so humbled. Thank you so much. With that, I will just get on with it because I think we are already running late. So I'm just going to concentrate on first trimester scan more than screening, because I think Pooja has covered a lot of screening, and Dr. Subodhi has covered quite a bit of multiple pregnancy as well. So we know that the reason why we do all these things is to be able to detect fetuses with congenital anomalies, pick up the pregnancies which are designed to develop preeclampsia, fetal growth restriction, and of course, prematurity continues to be the challenge. And to be able to reverse the pyramid of care by actually making a complete assessment in the first trimester. So pretty much screening and diagnosis is shifting to the first trimester. There are guidelines which I think most of you are very familiar with, and we're just going to go through these various important aspects in the first trimester scan, which is done between 11 to 13, sorry, the one is missing there, 13 plus 6 days, 13 weeks and 6 days. That corresponds to about 45 to 84 millimeters. Okay, so viability is very, very important, of course, and in the first trimester scan, we would check for the uterine integrity. I'm just going to primarily stress upon the ISO guidelines on the performance of the first trimester scan. What are the things that one needs to look out for? And one, of course, will look out for a possibility of a cesarean start pregnancy very early in pregnancy as well, hopefully not, and rudimentary horns, etc., ectopic pregnancy. Viability and measuring the baby's crown length is this is one of the most important measurements in the first trimester. And of course, I prefer the 11 to 14 week scan to measure the crown length, because you can see the ends of the baby much clearer. And of course, at the same time, you check the NT, the nasal bone, etc. And this one profile view will give you a lot of information about the baby, and we will come to that in a bit. Okay. And chorionicity, I've heard a lot about the chorionicity, the lambda sign for dichorionic, and the T sign for the monochorionic twin pregnancy must be established in the first trimester itself. Now, coming to chromosomal abnormalities, the only way you can be absolutely certain that is 100% confirmatory test is only by doing an invasive test, and that is the needle test, CVS in the first trimester, and amniocentesis in the second trimester after 16 weeks. And the risk of miscarriage is pretty low with experienced hands, and there is no difference between the two if you know how to do your CVS well. Now, why is it important to check the chromosomes of the baby? Is because even something simple as Down syndrome, there are two types of Down syndrome. There could be an abnormal just trisomy 21, which affects most pregnancies, but of course there are 3% or 3 to 4% which can be translocation Downs, and unless you check the chromosomes, the karyotype, you will not know whether this is a translocation Downs or this is a sporadic Downs. And why is it important? Is because of the risk of recurrence. The translocation Downs, the risk of recurrence is many times higher than the sporadic trisomy 21. And occasionally we can get caught out in the subsequent pregnancies, and many times you will see anomalies or markers, but sometimes you get caught out with baby can look completely normal on the scan, but still carry a translocation Downs. Okay, and of course the outcome, whether it is sporadic trisomy 21 or or is it a translocation down, the outcome is pretty much the same. Okay. Now, assessing for the common forms of aneuploidy is that as the mother gets older, the risk of having a baby with trisomy increases, and that this applies to trisomy 21, trisomy 18, and trisomy 13, of course. And as the CRL increases, the range of nuchal translucency also increases. Therefore, the nuchal translucency depends on the crown rump length because the NT range increases as with CRL. Now, we have heard about biochemistry. It is important, if we take only the biochemistry, the detection rate is pretty low with a high false positive rate. And in pregnancies with trisomy 21, the beta HCG tends to be higher, the PAPA tends to be lower. And when we combine all this information, this gives us nearly 90% detection rate for fetuses with trisomy 21. And this has been replicated in multiple units across the world and in India as well. And the detection rates are pretty good, provided you do the NT scan correctly and you do your biochemistry in certified laboratories or the correct laboratories, and it is done correctly. Okay. Now, this was a paper that we published a few years ago where we compared the nuchal translucency of 99th to 95th centile and more than 2.5 and 3.5 as well. And I'm sorry, this got missed out. There was there is a chart, and this is available online. There's a chart for each crown rump length. What is the 95th and the 99th centile NT? Of course, the more than 95th performs the best. There are additional markers, absent nasal bone, ductus venosus abnormality, and tricuspid regurgitation, which the markers can be present in normal babies and in abnormal babies as well. Therefore, when you see any marker, it is important to do a complete risk assessment with the number for working out for a personalized risk for that particular baby. Now, when we do the combined test, combining all this information, including the blood test, this gives us a reasonably good detection rate of 92% for a false positive of less than 5% and a pretty good detection rate for trisomy 18 and 13 as well. Now, when you add additional markers, that improves by another 2-3%. And if you do cell-free DNA and anomaly scan for all your scans, of course, your detection rate will be very high because cell-free DNA is a good screening test. However, in the absence of markers or abnormalities, right? And of course, if you do contingent screening, that is what we practice most of the time, that we do the cell-free DNA testing only in intermediate risk. I don't take 1 in 10, I take 1 in 100 or 1 in 200. And of course, we discuss with the parents also, because some parents will want to be absolutely 100% sure, irrespective. And in those parents where you want to be absolutely 100% sure, go with the invasive test, and only when, because cell-free DNA testing is only 99%. So taking up a 3-tier approach for prenatal screening, you do the first trimester combined to everybody. This, I think, would be economical also, because at the moment still the cell-free DNA testing is still much more expensive than the first trimester quadruple marker test. So if it's low risk, then you go ahead. If it's high risk, you consider invasive testing. If it's low risk, you can go ahead with the anomaly scan and the genetic sonogram if you wish. And if it's intermediate test, in this you will have a little bit of a dilemma whether to offer them a cell-free DNA, or some parents, as I said, will want to do invasive test directly. So if you find minor markers, particularly EIFs, short long bones, RPT, that is renal pelvic dilatation, or hyperechogenic bowel, you could still go ahead with sequential or cell-free DNA testing. But if you have more than one marker, or if you have 2 or more minor markers, or if you have a major marker, mainly ventriculomegaly, aberrant right subclavian artery, absent nasal bone, and nuchal fold thickness more than 6 millimeters, you're not only looking for Down syndrome, you're looking for other anomalies also. And in those situations, you will go directly with invasive testing and chromosomal array. Of course, if you find an anomaly, then cell-free DNA is out of the window. You need to do an invasive test and go for a chromosomal microarray. Because increased nuchal translucency can have other effects also, other causes also, like major defects like cardiac defects, skeletal abnormalities, etc., and genetic syndromes as well. However, it's important to investigate these pregnancies with increased nuchal translucency and not terminate them just like that, because depending upon the cause, you will be able to tell them what is the chances of recurrence exactly. So in general, you can say that if the NT is between the 95th and the 99th centile, then you may want to consider and self-free invasive testing, self-free DNA testing, and early anomaly scan maybe, fetal echo maybe, but certainly anomaly and fetal echo at 18 to 20 weeks, because increased nuclear translucency, you must do an echo as well. On the other hand, if you have an NT above 3.5, then cell-free DNA testing is not an option. Go directly with an invasive testing. Do an early anomaly scan, maybe an early echo also if you have the expertise available, but certainly anomaly and echo at 18 to 20 weeks. Okay, so let 3.5 be kind of a reasonable cutoff to make sure that you go and find out the reasons, because then you're not looking just for Down syndrome, you're looking for other anomalies as well. Now, I'll come to the systematic first trimester examination. The ISO guidelines puts up a protocol to look at fetal biometry, crown rump length, according to the gestation, because smaller crown rump length can be marker for trisomy 18 and certain anomalies, biparietal diameter and head circumference, abdominal circumference, and femur length, of course. Now, making sure that you take all these biometry in the first trimester, mid-sagittal view of the face, look at the profile, the nuchal translucency, and the nasal bone, the parasagittal view for the color Doppler, axial and Doppler for the 4 chambers of the heart, tricuspid Doppler, cardiac axis, and the uterine artery Doppler on both sides. So it's very important that we complete the checklist there. And of course, they give us a basic minimum requirement at the best practice where more advanced examination can be done for the baby. So a detailed examination will be much more, and we will go through each view as well. So the first trimester anatomical scan has become a very, very important aspect of the first trimester scan. So everybody who does the nuchal translucency or the first trimester scan should not only look at for the markers, but also should make sure the anatomy of the baby is reasonably normal, right? So looking at the overview, placenta of the fetus or the placenta, look for any echogenicities in the placenta, cyst, lacunae, subchorionic hemorrhage, and abnormally invasive placenta, and of course look for any uterus. So you're checking for the viability, you're looking for the number of fetus. Position and lie is primarily for the situs. You do not need presentation of the fetus, because obviously it's very obvious, because the baby is in a little swimming pool, so it will be rotating all over the place. So you don't need to mention unstable lie or things like that. That's irrelevant at this stage. Okay. Now, you can sometimes have a retroplacental space there, right? And that's likely, again, this is something that is more, it's overdiagnosed rather than, rather than really being there. Okay. So many times this is just the amniotic membrane that is separated from the baby. Now, the other important space that you need to look out is the retroplacental space, because particularly in the previous cesarean section, because that can give a clue to possibility of past, that is the placenta accreta spectrum there as well, right? Then look at the placental cord insertion and use color Doppler, reduce the gate, so you can actually look at the cord insertion very well, okay? Now, sometimes you see something like this. It's very obvious. This is a molar pregnancy with a normal fetus as well. So this is a dichorionic pregnancy with molar placenta in the second sac. So need to look out for those things. In the uterus, look out for fibroids, amniotic bands, and AK as well, because you can see them very well in the first trimester itself. Coming to the amniotic fluid and membranes, the amniotic fluid is more or less a subjective, subjective assessment, and the amniotic membrane is not fused. And look out for any echogenicity in these areas, because that would indicate clots. But this is not a subchorionic hemorrhage. Please be sure that make sure that you don't overdiagnose in unnecessary hemorrhages which is not there. Of course, if it's a multiple pregnancy, you must check for the chorionicity and the amnionicity, which has been spoken about. Now, when you're looking at the primarily in monochorionic twins, you look at the discrepancy in the amniotic fluid discrepancy, you look at the membrane, this membrane is very close to this fetus, and therefore you know that the amniotic fluid is very different. Now, this is what I was telling you about the subchorionic. You see a lot of echogenicity there, haziness, from the white, and that is clearly a blood clot and not another sac. Right? Again, not an infrequent mistake thinking that this is a lambda sign. Okay, so when we are looking in the first trimester, we are going to go through these abnormalities. That is a target 9. Coming to the head and brain, when we look at the head brain, again, 3 views have been described: the transventricular, transthalamic, and transcerebral. So you see the skull, completeness of the skull, the midline, and the choroid plexus, which is the echogenic areas. And then you can see the thalamus, and you go a little bit behind, you can see the choroid, you can see the cerebellum as well, particularly in 13 weeks. And of course, there is a newer marker called the choroid bar as well. I've not included that here yet, okay, because I'm sticking to the ISO guidelines currently. Now, again, when it doesn't take much, it just goes 1 millimeter, 2 millimeter down, and you can pretty much see this very, very quickly, and you can get all the 3 planes very quickly. Now, what are the abnormalities that you can see in the head and brain? The complete absence of the skull, which is acrania. You can see a breach, that is encephalocele, breach in the cranium, that you can see the encephalocele. Okay, not very difficult to see at all. But remember, encephalocele, sometimes you can have in very awkward areas also. It's not always necessary that it is in the posterior part or in the occipital. But here you can see that encephalocele is the front. It's a frontal encephalocele, right? You can see the brain matter hanging from the front. So don't make sure that you look at the entire skull and that there is no breach, but don't mistake the suture lines for breaches as well. Now, in the head brain, you don't see the midline, and very much in the profile view itself, you can start suspecting because there is too much of black. And when you turn your probe around and put it in the axial view, you can see that the midline is completely missing, and the brain also looks, thalami looks fused. And this is a alobar holoprosen. Okay. Now, coming to the face, again, 3 views in the face: the mid-sagittal profile, which is the most popular view, the axial view looking at the orbits, lens, maxillary process, and the oblique coronal. So when you look down to the face, you go side to side, turn your probe, look at the axial view. You can see the 2 eye sockets very clearly. You see the premaxillary triangle, and of course, you see a mandibular gap that is present. So profile, eye sockets, PMT, and mandibular gap is present, whereas the maxillary gap is abnormal. Lack of mandibular gap is the mandibular gap is normal. Okay. So all these brain abnormalities that you had seen here almost picked up in the profile view itself: acrania, encephalocele, and holoprosen cavity. So the face gives you a lot of information. Now, coming to this, you can see that this is the maxilla. Nuchal looks okay. The brain structures looks okay. So as you're coming to the looking at the maxilla, there is a little gap there. It should be bright white like that, but there is a little gap. You can see that. Okay. So, and then you rotate it rotate it to the axial view, and then we can see the lack of premaxillary. There is a gap in the premaxillary triangle as well. So this is highly suggestive of a cleft of the palate. Now, when you have a cleft of the palate, it is important to look for other anomalies because it is a part of spectrum of trisomy 13. Okay. Sorry. Okay, now the other one is the chin, right? The micrognathia. So you can very clearly, obviously, see this is the micrognathia. It's not rocket science. This definitely does not look like this chin because you can see that all the 3 are in the same line. The frontal part of the skull, the maxilla, and the mandible, they're all in the same line. And here, if you draw a line, the mandible is placed backwards, and of course, there is increased nupal translucency also. This gap is normal, the mandibular gap. Now, let us look at something a little bit more difficult. Now, you can see that this is, sometimes you feel it's there, sometimes you feel it's not there. So you're not very clear whether there is really a micrognathia there or not. So in these situations, it would be very helpful to draw a line. You can see clearly, you get a perfect mid-sagittal view. you're finding it difficult. And then when you turn the probe around, you can see that there is a loss of the mandibular cap. This is normal. This is abnormal, right? So clearly there is micrognathia in this particular fetus. Now, micrognathia is very important because you know that it can be associated with trisomy 18, 13, and many genetic syndromes as well. Now, other facial abnormalities you can pretty much suspect. Of course, in this baby, there was not a prosectomy also, but you're trying to constantly look at the eye sockets, which you can very clearly see on the second trimester scan. You do not see the eye sockets at all. And this is severe microphthalmia. Again, a marker for trisomy 13, and of course, many genetic syndromes. Also, you can have microphthalmia. And you see the profile is very abnormal. So you can start suspecting it from there itself and then go and get additional views and then pick up those abnormalities. Then, of course, the most frequent abnormality in the neck is increased nuchal. But when you're looking at the neck, it's also important to look at the attitude of it. Sometimes you can have a hyperextended or a hyperflexed. Even as you're taking your CRL, you know straight away that that baby is looking, that neck is looking good. Now you look at all the translucent spaces, the nuchal translucency, the intracranial translucency, look at the bony occiput, the continuity of the skull, and any soft tissue masses as well. So the completeness is very, very important when you are assessing the neck of the fetus and not just looking only at the nuchal translucency. So you have a sagittal view, you have an axial view, and you have a coronal view. So important to assess the neck in all the views, right? Increased nuchal translucency cystic hygroma is the most common abnormality of the neck. And again, you can have just a mildly increased nuchal translucency. It's not that significantly increased. And therefore, sometimes, if you do not magnify or if you do not follow the Fetal Medicine Foundation guidelines, you may actually miss out on these slightly increased nuchal translucency. And this is also very important because many babies with Down syndrome will have actually only slightly increased nuchal translucency. And, it may not necessarily be all cystic hygromas. More cystic hygromas with trisomy 18 and Turner syndrome, slightly increased nuchal translucency with Down syndrome, right? So that's how the pattern is usual, right? Not always, usual, okay? Increased nuchal translucency and again cystic hygroma. Moving on to the thorax and the heart. Then heart, again, 3 views, 4-chamber view, the 4-chamber with color Doppler and 3-vessel trachea view. So important at this stage, you're looking at the lungs also and making sure that they are uniformly echogenic. The cardia is placed correctly. Look at the axis, look at the atria, look at the ventricles. Of course, you need a little bit more experience looking at the first trimester cardia, and building a good amount of experience in the second trimester will help assess the first trimester cardia much better, right? And if you are more experienced, you can go ahead and use the color Doppler, which is very, very useful. You can look at the color Doppler 2 inflows, you can see outlets, and the moment you see your D sign, then that you know that the outflow tract are also good. And we actually presented a poster some years ago in this information where we actually picked up quite a few outflow tract anomalies in this just by putting color Doppler and assessing the heart on the color Doppler and making sure there are 2 inflows and the X and the V signs. Okay. Now, if you see a mediastinal shift in the first trimester, you have to go looking for the stomach. Okay. Now you can have a stomach up or stomach down. Sorry, this is plain. You can have the stomach up or stomach down. In this particular case, right next to the heart, you have a cystic area. So this is likely to be a congenital diaphragmatic hernia. Now, cardiac anomalies in the first trimester, the other markers are trisomy for cardiac anomalies is tricuspid regurgitation and abnormal ductus venosus. And if you have all 3 markers, then the probability of a cardiac abnormality is significantly increased. Now, atrioventricular septal defect is easily detected on the 4-chamber view, but on the color flow also when there is a single outflow tract, you do not see the V that I told you about. You get 2 inflows, but when you come to the outflow, there is a single and it is a reverse. So this is known as a reverse boomerang sign, and that's a marker for transposition of great arteries. And then you know that very likely you're dealing with the TGA there. And of course, if you're not confident enough, it's always better to bring them back at 16 weeks, reassess the heart, and then call it a cardiac defect rather than jumping in the first trimester itself. And this, I think the more you do, the better it gets, and the more experience you gain, the more confident you will get. Because scanning is something that only comes by doing more and more and more and seeing more abnormalities as well. Okay, now again, cardiac anomalies. This was quite a significant shift, mediastinal shift, and you can see quite enlarged, and you can enlarged heart as well. In fact, heart is occupying almost 50% of the thorax. There's a large VSD as well. So if you suspect, I mean, this is very obvious, but sometimes it can be a little bit more difficult. Let's see if this will play. Okay, it's waiting to be played. Now, I think this is a right side aortic arch is taken. Okay, so sometimes you may see certain abnormalities that are not, not so bad as this, the other one, like large VSD, VSD tracker. Oops, sorry. I'm so sorry. Okay, so that was a right. That's not this. This is normal use. So this one was I think it's an Epstein's. Yeah, and then of course there is an abnormal ductus venosus there as well. This was a right side, right aortic arch that we detected in the first trimester, and these ones we would just tell them to follow up in the sorry picture there. It's not like, my apologies. Okay. Okay, moving on, coming to the abdominal wall. Again, 3 views: axial view, pelvis, looking at the bladder and the arteries and the kidneys as well. So axial view, I always like to measure the stomach, the abdomen at the level of the stomach. Is something that we got used to, and that also assures us that we have seen the stomach in its proper view. Okay, and the 3 vessels of the 2 arteries of the umbilical cord, and in the coronal view, we would look at the kidneys. I don't know why some of these videos are not playing. Sorry, thought it was playing. I have not changed my laptop, but anyway, get the coronal artery, coronal view, look at the bilateral kidneys and the thoracic and lumbar spine as well, and the pelvic bones as well. You need to look at that. Bilateral kidneys, you can check the renal arteries, and then you will know that both the arteries are present. That means there are 2 kidneys. If you don't see the stomach bubble in its usual place, then either it could be a diaphragmatic hernia, because you go around and look at the chest to see whether it is a diaphragmatic hernia, or if you don't see the stomach bubble in its usual place, and you can see here the stomach is there, but the heart is pointing in the opposite direction. So think of situs anomalies as well, if you don't see the stomach. So not seeing the stomach bubble is something that you need to be worried of in its usual place. Okay. Then you see a huge big cyst in the first trimester in the fetus. Okay, and that is almost always a megacystis unless proved otherwise. Then you have a small, sorry, it's not playing again. So the large megacystis, which is more than 16 millimeters, are more likely because of the lower urinary tract obstruction, whereas the smaller ones, that is less than 15 millimeters but more than 7 millimeters, they are more likely to be associated with aneuploidies, and many of them will spontaneously resolve, and this could be a normal variation. Okay. Now, sometimes you see something. This one was referred to as megacystis, and of course there was megacystis as well. But in addition, there was a very short cord. So sorry, I am so sorry. Anyway, there was a very short cord, and the baby was completely pulled up and attached to the placenta almost, and that was also a body stalk anomaly. And these are lethal abnormalities, as you can see. So sometimes you can see non-stomach bladder abnormalities. You can see this. There is a cystic space there, but it is not central, right? It is more towards one side. So you can sometimes have non-bladder and stomach cystic areas. So you have confirmed that the bladder is in the right place, the stomach is in the right place, but you have an additional cyst there. And in these ones, many of them will be benign, but you need to look out for them and arrange for follow-up scans. So these are just abdominal cysts in the first trimester. I would generally not like to categorize them as something because many of them will just disappear spontaneously, or they can change in subsequent scans. And it's very difficult to be very categorical about the origin of the abdominal cyst, even in second, third trimester sometimes. So first trimester, I would always be cautious about where it is coming from, and give that baby a chance by following it up after 3 weeks and around 16 weeks and see what's happening. Okay. Now coming to the abdominal wall. Abdominal wall, again, axial views, you can, at the level of the umbilical cord insertion, you have to look for the intactness of the abdominal. Can use colored Doppler also, but what is extremely important for me is I always like tell this to everybody, that when you are assessing the cord insertion, you have to make sure that the stomach wall, the skin is touching the cord on both sides, so that you don't miss out on small exomphalos, because it is the small exomphalos that is more likely to be associated with aneuploidies, whereas the large exomphalos are less likely to be associated with aneuploidies. Now, this is a large exomphalos. If you actually, basically there was a huge exomphalus. Sorry, but you can see there is a huge disproportion between the baby's head and the stomach, because the whole liver was sitting outside. Now, in this particular case, there was a very small example. There was just echogenic areas inside the umbilical cord, and these are more likely to be associated with aneuploidies, particularly trisomy 18, and many of them will resolve. So you will assess the chromosomes for this baby, and then wait for till 18 to 20 weeks, and then some of them will resolve, and then they can have a good outcome. And of course, small exomphalos are better, more amenable to surgery. Now, gastroschisis is also another anti-abdominal wall defect, where there is where the intestines are floating freely in the amniotic cavity. The association with aneuploidies is not that high, but I would still confirm, because now you can do many genetic syndromes, chromosomal microarray, etc. There may be some associations there. We don't know about that. And it has got a reasonably moderate prognosis. So if the couple are willing to, subject the baby to surgery and look after the baby well, then we may, carry on the pregnancy. But of course, will require close monitoring in the pregnancy itself. Now, coming to the umbilical cord. You need to look at the umbilical cord insertion. 2 umbilical arteries I've already shown you in the bladder view. And of course, the placental cord insertion also is a good thing, because now membranous cord insertion or velamentous cord insertion you can pick up, and those pregnancies have a more likely to have an adverse pregnancy outcome. So it will require more follow-up. Now, umbilical cord abnormality is a single umbilical artery. Is something that you need to look out for. Umbilical cord cysts you can have in the first trimester itself, and these are associated with trisomy 18, fetal growth restriction. And once you've checked for markers for trisomy 18, then you can follow up as well. Okay. Coming to the spine, I always like to see the spine directly. Again, sagittal view and the coronal views of the spine, looking at all the bodies, all the ossified vertebral bodies in both the views, in the sagittal and the coronal view, right along the length. Now, if you find that there is, significant hyperextension of the neck, as you can see, there's hyperextension of the neck there, the neck, you're not getting a good CRL at all. That's likely to be an anemia. Here you can see there's quite significant types of scoliosis in the spine as well, although the skin looks intact. So there are a lot of spinal anomalies you can pick up in the first trimester itself. There's obliteration of the intracranial lucency, and you can see that when you look at the spine, there is an almost lemon-shaped skull right now itself, and there's a cerebellum is pulled back, and there's a loss of system and there. This is the crash sign. And when you go down, you can actually see a spina bifida. There's a vaginal scan, and then you can see that there was a spina bifida. There's quite a significant spina bifida. So there are multiple signs that have been described for spina bifida, but again, nothing replaces direct visualization, because sometimes these signs may not be present at all. Now, coming to the limbs, again, important to look at all the three segments of all the four limbs. There's the arm, forearm, and the fingers, and the legs, from the two femora to the to the tibia fibula, and the feet as well, because you can sometimes have part of the segment missing, or part of the limb, part of the entire limb might be missing, or part of the limbs might be missing, etc. So, and then of course the other one you have is a short long bones. You can see this baby has got an increased nuchal translucency, and the limbs are very, very short. And therefore it is important to assess the length, visually at least assess the length, and if you're suspicious, then measure it as well. This you can see was quite a significant club hand, and this was at 13 weeks. There was an extension of both the limbs, and there was no flexion at the knee at all. Despite several attempts, the baby was not moving, it was not flexing its knees at all. And this is a cerebral. So these are very awful anomalies that can be detected in the first trimester itself. Now, of course, certain genetic abnormalities can be very specific to the gender. Also, in those situations, you need to be able to assess whether we really need to do a CVS for this baby or not. And of course, it is a very, very responsible job. And we look at the genital tubercle to assess the possibility of whether we should do a CVS for this pregnancy or not, because there are certain genetic, like DMD has got a 50% chance of affecting the male fetus, whereas in the female fetus will be only a carrier, right? So apart from this, many genetic abnormalities can be detected in the first trimester based on the morphology, and of course doing the CVS. Look at the family history, look at the history of consanguinity, past history of miscarriages, anomalies, pattern of multiple anomalies, and of course look at markers as well, because many of the markers for chromosomal abnormalities will overlap markers for genetic abnormalities as well. The most important thing is to have a high index of suspicion, and no baby with multiple abnormalities should ideally go without being tested, or without being given some sort of chances of recurrence and help in terms of for the future reproductive life. Okay, there is very limited role for 3D and 4D. It is not currently used routinely, but some anomalies it can be helpful to evaluate. So very important to look at the first trimester. In majority of the babies, the good assessment of the first trimester anatomy will be very, very reassuring for the vast majority. And we have shown that many abnormalities will be picked up in the first trimester itself if you really look for it carefully. So you can call them always detectable because they'll always be present. Some can never, and some will be potentially detectable. So I'm just going to skip these things for want of time. But also we must remember that there are some defects which cannot be detected in the first trimester because of the in utero evolution of that particular abnormality. It can be progressive in the second trimester, and sometimes even in the third trimester it can be detected. So as obstetricians, as radiologists, as sonologists, as anybody dealing with the fetus, we need to know in all three trimesters which are the abnormalities that must be detected and that are detectable only later on. And of course, ISOA gives you a guideline on what are the things to report as well. So it should be a universal assessment. In majority of the pregnancies, a normal anatomy is very reassuring. An anomaly that is detected early must have a proper genetic diagnosis. It should be a protocol-based approach, and a transabdominal and transvaginal scan are complementary. If you get very good views abdominally, there's maybe no need to do transvaginal. But if you don't get good views, you need to go transvaginal as well. I'm just putting up that list again for people, that anybody who's doing, even beginners should be able to detect these abnormalities in the first trimester always. Okay, so thank you very much. And it is our duty at every scan that we have to prove that the baby is normal. We cannot start saying this baby is normal. We have to exclude abnormalities and prove that this baby is normal. Thank you very much. I'm sorry I've exceeded time as well.
Thank you very much.
Eclampsia very important, and give aspirin if the risk is more than. Thank you.
Thank you very much, Dr. Pratima, for a very lucid talk, which has been delivered very, I think, clear and crisp message, and it was very informative. Thank you very
My
much.
apologies for not playing the videos properly. I'm so sorry. But maybe that would have taken a longer time.
Dr. Nagarna Madam is with us.
Yeah, good evening. Yeah, madam, it was an excellent talk.
Thank
And you
you,
covered the entire anatomy from head to toe. So, and also the videos, some of the videos which you played were excellent videos, and we really appreciate the detailed anatomical study, madam. It was very nice talk.
Thank you, Dr. Nagarna.
And
Thank you,
as
ma'am.
it's really a very great learning experience with Pratima Madam, as always.
Yes,
Thank you so
ma'am.
much, Dr. Rashmi.
Thank you.
Thank you so much, madam.
So,
Okay,
Buri
any
Madam,
question?
would like to hear from you.
Yeah.
About the talk? Oh, Dr. Pratima is always excellent. I know her for a long time. I think when I started my first interest in fetal medicine, long time back, when we used to go to Apollo to get the first trimester scan done, and she with Dr. Anita Kaul actually taught us a lot of things, and we try to follow all those things, ma'am. So it's
Thank
always
you.
excellent.
Thank you, Dr. Subramanian. Thank you.
And the videos
Ma'am,
were
it's
also very
really
good.
great to have you today. Seriously.
Yeah.
Thank
I
you
was
so
just
much
thinking,
for
I was
this
just salad in
lecture.
between the two good dishes. I just served salad. मेरा बहुत छोटा था. So I thought कि मैंने time bound होके काम किया क्योंकि I was just thinking कि बहुत लंबा था.
And
So
Pratima
it was
Madam,
nice.
officially from the team, we congratulate you for this 2024 DSV Mrs. Diva award. Many congratulations, ma'am. You are really an inspiration for all of us.
Thank you so much.
Everyone of us. Thank you so much,
Thank you,
ma'am, for
Rashmi,
being
for
here.
inviting.
Thank you, Sujit. Thank you, Jack.
Thank you, Dr. Sujit. Okay. And thanks,
Yeah,
Pooja.
also
It was
let
a
us-
nice and excellent talk. And I could see that you was not listening to my talk, and that was not good. I talked well
completely
too.
I was.
You
can
ask and check. It's fine. It's fine. So it's like, okay, good.
I was there for both
Great
the
to
talks.
connect here. Yeah, so great to connect, and a big
Nice.
thank you to Dr. Rashmi and Dr. Sujit. इसी बहाने अच्छे से पढ़ाई हो जाती है. I just
आपकी
trim
पढ़ाई
the
रहती है,
skirts
प्रतिमा
of the small
मैडम
lizard.
पढ़ाते रहते हैं. आपकी
हाँ,
पढ़ाई
पढ़ाते हैं.
पढ़ाते
मेरे को
रहते हैं.
बहुत पढ़ना पड़ता है हर बार. This time
Actually, आपको
I
मालूम
didn't check
होगा,
the videos, but I still read what I need to read.
Yeah.
I started taking interest in fetal medicine from Bangalore Fetal Medicine Center at Pratima Man's Institute.
Thank you.
Oh, great.
Yeah,
She is an inspiration for all of us, no doubt.
yeah, right.
And when
That's
I
for
asked her, she
sure.
was like ready for this, and I was very happy that she could manage and
Exactly.
be here.
Exactly.
Now I'm planning to start my
Thank you so
grooming
much.
under Pratima ma'am. There's one more thing to learn from her.
That's great.
You don't need. You're very good at the so all of you are wonderful. It was just one whimsical moment that I just went there and it just happened. But I worked very hard for that one. It was not easy. Yeah, I will make a presentation on that one someday.
Ma'am, what was the winning question, if we could ask you? They have those moments.
Pooja, you should ask winning. Pooja, you should ask Madam winning photos actually. I have seen on other.
I thought we are already offline. Okay.
Are we not offline?